हेलो फ्रेंड्स, वेरी गुड आफ्टरनून टू ऑल ऑफ यू। कैसे हैं आप सब? आई होप you all must be fit, fine, healthy, and busy with your studies. Now, if you say today is 14th of September, and I think roughly we are left with 89 days. If we see on one hand, the 89 days are very little because you are having roughly around 19 subjects. So we are having around 4.5 days for individual subject, and we know that in each day at least 6 hours sleep is required. Then we have to give 1 or 2 hours for our daily activities, for our lunch, dinner, breakfast. So roughly we are left with around 14 to 16 hours per day, and after that 14 to 16 hours you are having your 8 to 10 hours classes also. So you have to read those subjects also, and you have to revise the previous subjects. So if you see on one hand it is too little, but if you see the other hand, I can say that this 89 days are sufficient if you are studying hard from your previous 2 to 3 months. Okay, so before going further, first let me know whether everything is fine or not, and audio and video is fine. So please give me a message that audio and video is fine. So I'll wait for a minute to get your messages that everything is fine, audio is fine, video is fine. So please give me a thumbs up or any signal. Okay, yes. So everything is fine. Okay, from the few students I am getting the signal that everything is fine. Okay, so what I was saying that these 89 days are sufficient if we say that you are studying hard. Okay, great, great, great. So if I say that if you are studying hard from your previous 2 to 3 months, absolutely, or not only for the past 2 to 3 months, but in your last 5 years in the medical curriculum, you had also studied. So that is also included in your previous studies, because that has already made your platform or made your foundation, and on that foundation you are preparing a building. So as we know that a foundation stone are strong, or the foundation is strong, then definitely the building will also be strong. So you had a good foundation, and then you are trying to build up the stories, multi-story building, and definitely it is going to be strong. So if I say for the last the remaining 89 days, that everything will be fine if you are going to do the study in the same systematic manner, utilizing each and every second of your time, and dividing your schedule in the small targets, and definitely you will be going to complete your syllabus by the October, and then you're having ample time to revise in the month of November and the first 10 days of the December. So we are planning our schedule in that way that you will have a complete one time course, and then you are able to revise at least minimum 3 times before appearing in your examination on the 10th of the December. So here this session is the clinical case discussions, or what we say the CCD. And as we know that now the pattern is changing. Now if we see the pattern of the NEET 2021, what we had on the 11th of September, only the 3 days back, and there also earlier we were expecting a very big clinical based scenarios of 5 liner, 6 liner, 7 liner, but that was not the actual happening there. And we had the maximum the 2 to 4 liner questions were there, and they were based on the basic clinical concepts. Although the 1 liner was very less, the image based questions were there. 20 to 40% were the image based questions, or in the one question they had included the images, but mainly they were the practical concept, and they had given a 2 3 liner story, or the points related to that particular problem, and they'd ask the question. Now, here, as I always say, and I am again repeating the same thing, that you have to learn to identify the key words in a given question, because the key words are very, very helpful in reaching in a proper direction and trying to solve the question, because examiner is framing a question in that way that if you are able to identify all the keywords and if you are able to correlate all the keywords, then definitely you will be coming to a correct answer. But if you are not able to identify the keywords and if you are not able to correlate those keywords, then definitely you may be distracted from your tunnel or distracted from your path, and you will be going to a wrong answer. So here with the different clinical situations, we'll try to learn that how to identify the keywords and how to solve the a few questions. And with these questions, we'll try to revise the important points of that particular topic also. Okay, so now we will start our discussion of clinical case situations in community medicine. Now, before going to the questions, now I'll say that in a life, always we are juggling between the two ropes, and one rope is the rope of your hope, and another is your rope of faith before falling in any problem. So, right now, I can say that till exam, you are not going to leave these two ropes. Whatever the situation will come, whatever the up and downs will come in your life, in your moods, you will be having a mood swings. The one day you will think, okay, my preparation is very good. Another day you will be thinking, oh, I am not able to remember anything what I had read even the a few hours before, or what I had read 5 days before. I am not able to remember. Then how I am going to recall all these points in the examination hall? But remember that always try to hold these ropes, and this is the rope of your faith in yourself, in your self confidence, in your hard work, and your faith in the God, and the hope that yes, everything will be fine. I am here to do, I am doing my best, then definitely my result will also be the best. And as I again say that always have a positive thinking in your mind. Now, whatever your low situation may be at this moment, you should try to enjoy. Okay, yes, I have achieved this because I've done in hard work, and definitely whatever the mistakes I am doing, I have to rectify, so I'm not going to repeat them again. And one more success mantra which I can share here is that never leave any sort of test which is being conducted by the institute, whether it could be a weekly test, or it could be any exercise, or it could be any your mock test, grand test. Because what we sometimes think, okay, my preparation is not good, so I'll not appear in this weekly test, I'll get the question later on and I'll answer. No, because what happens when you're appearing in the test and you had all those impact of your mental, social, and emotional factors which is affecting your performance, and you have to see that how silly mistakes you had made, and those silly mistakes you have to rectify, and that will help you in reducing the number of the mistakes in your coming examination. Clear? So with these words, now we'll be discussing the a few questions. Now here, this is a one. Now suppose if I say that this is, just give me a minute, I think this logo is disturbing, so I'll make it short as much as possible. Okay, now fine. So now whenever the 4 5 liner question is given, so what we have to approach, or how we have to approach, is that we should try to read the last line. And if the image is given, we have to see simultaneously the image. Then we have to look for the options. Now many times they will give you the story and only the one line has been asked, and that is enough to answer the question. Now the question here is that which type of the graph should be best illustrating the data. So it means they are asking about the various types of the graphs, and the options quickly are the bar chart, histogram, pie chart, and the line graph. So they are talking about the different methods of the data presentation. So while reading this last line and the options quickly, it should come in your mind that what they are talking about. So they are talking about the certain data representation methods, and quickly we know that we are having the quantitative data and the qualitative data presentation. So now we have to read the previous line because we have to identify what they are talking about. So the question is that you are preparing a report to represent to the government of India on the incidence rate. So they are talking about, the one keyword is the incidence rate of the corona infection in your state in the different age groups. So they're talking about the different age groups, the 0 to 5 years, the 5 to 10 years, 10 to 15, and so on for the last month. So now here I think you all must have guessed this word, that they are talking about the back-to-back values, 0 to 5, 5 to 10, 10 to 15. Okay, so they are talking about the incidence rate, and they are talking about the continuous values. So continuous values are there, and they're talking about the incidence. So incidence we can calculate. So they're talking about the quantitative data. Okay, so they're not talking about the qualitative, so they're talking about the quantitative data. Clear? And they're talking about the continuous data, 0 to 5, 5 to 10, 10 to 5. And we know that the best way to represent is the histogram for continuous quantitative data. Clear? So now we have to look at our option. The bar chart, no, because why? This bar chart is used for the qualitative data. Now histogram, this could be. So we are keeping, okay, this could be. And again your success mantra, that how much you are confident in your answer in the option A and B, but don't jump to tick. Give a 2-3 seconds time to read the other options also, because you may find some better answers sitting on our option number C or the D. So why to lose a single mark? Okay. Now pie chart, again this is for the qualitative data, so this is not used. The line graph, line graph is for quantitative data, but it is not for the continuous. It is showing the trends of the events over the time. Clear? So here the correct answer is the histogram. Now quickly we'll revise that what are the various other methods for the data presentation. So if we say, because these are your image based questions also, and they can be the concept based questions also. So these are the various data presentation for your quantitative methods, quantitative data, and the first is your histogram. Now histogram, it is the continuous quantitative back-to-back values are there and there is no gap. Clear? Now the number 2 is your frequency polygon. Now frequency polygon is basically base is the histogram, and if you are joining the center point on the top of this histogram, whatever the curve we are getting is the frequency polygon. Now if the frequency is very high, means the interval is less, and we are joining these dots, we are getting a curve like structure. So this is your frequency curve. Clear? Now this is your I'm not writing each and everything because we had written in our class notes everything in detail. This is just a quick revision. Now this is your line chart. Line chart is showing the relationship between the two parameters or the trends of the events over the time. It can go in any direction. Okay, like we have to represent the relationship between the age of the baby and the weight of the baby, or the relationship between the time and the incidence rate in the past a few months of the corona infection, if you want to say, but not the back-to-back values. Like here they are saying the 0 to 5 years, 5 to 10, 10 to 15, like that. Then it will be your histogram. And this is image number 5. It is for the scatter diagram, and with the knowing the imaginary line are shown on these dots, we can see that what type of the relationship is there. We can calculate the correlation coefficient, And if it is increasing in direction, then it means it is a positive correlation. If you're increasing the one value, another value will increase. Or we can have the negative association also, that if we are increasing the one value, the opposite value will reduce. So this is the scatter diagram, and we are calculating the correlation coefficient. And one more point here is that the range of the correlation coefficient is between a minus a 1 to plus a 1. So this is the range, and we have to remember the two more ranges as the PQLI. What is the range of PQLI? Please answer me. I'll wait for your answer. You all had my WhatsApp number, so please message me that what is the range of the PQLI. What is the range of PQLI? What is the range of PQLI? Whether it's a 0 to 1, 0 to 100, or minus 1 to 0, or a 0 to plus 1. So what will be the range of PQLI? Okay, excellent, excellent, excellent. So those who are answering the 0 to 1, dear, this is the range of HDI. So HDI is having the range of 0 to 1, but the PQLite is having the range of 0 to 100. So don't worry, don't feel upset if you are answering the 0 to 1. It is just a revision. This is why we say that whenever we recall anything, we have to correlate. So PQLI range is 0 to 100 and the HDI range is 0 to 1. Clear? And the range of the correlation coefficient is minus 1 to plus 1. Now, if we go with the various qualitative data presentation methods, now qualitative data presentation method is the bar chart. Now, this is again very commonly asked in the examination, and here we have to differentiate with the histogram, because you could see in the histogram there was no gap. But here in the histogram, there were this bar chart, there was a gap is there. But now we had seen in the NEET PG exam also and in your FMG exam also, now they are asking about the different types of the bar chart. So see these three graphs very carefully. Now all are the bar charts. Now this is number one. This is again a simple bar chart. What we can say that there is a gap between the values. So that's why it is different from the histogram. Now this is also a bar chart, but here it is on the same bar they are showing the different percentage of the value or different components of the value. So this is your component bar chart. Component bar chart. Clear? And if you see in the image number 3, now some of you may say that this is your histogram. But mind, please see carefully that this is not an histogram, because here there is definitely a gap is there. So what actually they are doing, they are showing the multiple values at a point. Now you could see the three different colors and the same colors they are carrying. So what these three different colors are, that they are the blood groups of the different individuals in the different countries. So they are talking about the blood group of the different individuals in the different country, and the same color persists. So this is your multiple bar chart. Clear? So suppose if this image number 3 is given and your options are whether this is a histogram or this is a bar chart or the multiple bar chart or this is a component bar chart, so your correct answer should be it is a multiple bar chart. Clear? All these are for qualitative data presentation. Clear? Now this is the pie chart. Image number 4, it is the pie chart, because here we are representing the values per 100 or per 360 degree. Image number 4 is the pictogram, where we are picturizing the values, and the image number 5 is the spot map analysis. So all these are used for the qualitative data presentation. Clear? So with this question we had discussed that what are the various methods of the data presentation. Now the next question is, among the women aged 18 to 34 years in a community, the weight is normally distributed. So one keyword is there is a normal distribution of the weight. So this is a one keyword. The normal distribution of the weight is there, and the mean weight is 52 kilogram, and the standard deviation is 7.5 kilogram. Now, what percentage of the women will have the weight outside? Now, here again, now many a time we cannot focus whether they are asking about the outside or inside. So they are asking that how much percentage of the weight will be outside the 45.5 to 59.5 kilograms. Now this is a little bit a difficult plus a numerical based question. Now first of all, we have to see that what are the various weight range of the normal distribution pattern. We know that in a normal distribution pattern, what is a Gaussian curve distribution is there, we all know this, and here the value between the plus minus of the one standard deviation of the mean value, it is covering around the 68% population. The mean plus minus of the two standard deviation, it is covering around 94 to 95% population, and the plus minus of the three standard deviation, it is covering around 98 to 99% population. Clear? This we all know. So with these points, like we had the mean weight with the standard deviation of 7.5 kilogram, we will be calculating the weight range of the students, a weight range of the women in this weight range. So what will be the weight range of these women within a plus minus of the one standard deviation? We know that 52 kilogram is the mean value, minus 7.5 kilogram, the plus 7.5 kilogram. So that will be coming between the 44.5 to 59.5. And this is what they are saying, that 44.5 to 59.5. So within this, so the value what they had given, it is corresponding to the plus minus of the one standard deviation, that is clear. Okay, and this is covering the 68% of the population. Clear? But the question is that what is the outside? And we all know that the values within this plus minus of the one standard deviation, if this is a covering the 68%, then outside will be the 32%. Now they are asking only outside. So outside will be 32%. Now to make it more difficult, sometimes they can ask how much is below this and how much will be above this. And I think we had discussed this type of the questions also in our Telegram group repeatedly. So below the 44.5 kilogram, that is the minus one standard deviation a point, and the 59.5, that is your plus one standard deviation a point. So below this minus one standard deviation point, we are having the 16% values, and above this plus one standard deviation, again we had the 16% values. So total is 32% outside the 68%. Clear? I again repeat. Now they had given us a range of plus minus of the one standard deviation, that is 44.5 to 59.5 kilogram, that is the plus minus one standard deviation of the 52 kilogram of the mean, and plus the 7.5 kilogram of the standard deviation. But the question is they are asking outside. Suppose if they had asked how much is the value within the this range, then answer was very simple, that was the 68%. But they are asking outside. So outside will be 32%. Clear? But I had made it further clear that if they had asked in future, suppose in the next question they frame that how much is below the minus one standard deviation, or how much is the below 44.5 kilogram, it is the same, that will be your 16%. And how much will be above your plus one standard deviation or above a 59.5, again there will be your 16%. But they are asking us a total. So here the correct answer to this is, it is 32%. Okay, so now quickly we'll have a look on our this Gaussian curve or normal distribution pattern, and we say that this is your bell shaped. This is your first feature. It is bell shaped. Okay, I'll make pointer, just a minute. Okay, so if I say that this is your bell-shaped or Gaussian curve, which is bilaterally symmetrical, and that is situated in such a way that a mean, median, and mode are the same. 50% of the values are above the mean value, and 50% of the values are below the mean value. The values between the plus minus of the mean, one standard deviation, the mean is covering the 68%. The values between the plus minus two standard deviation of a mean is covering the 94 to 95%, and the values between the plus minus of the three standard deviation is covering the 98 to 99% population. So these are the very important features very commonly asked in the examination, and here the very important is the mean is equal to median to the mode if it is a normal distribution pattern. But suppose if it is your a right skewed deviation, and how the right skewed deviation is there, that here the a long tail is towards your right side. So this is your right skewed deviation where the mean is maximum followed by the median and the mode. And suppose if it is your left skewed deviation where the long tail is towards your left side, so this is your left skewed deviation, and in the left skewed deviation the mode is a maximum followed by the median or mean. Clear? So remember these distribution patterns and the relationship, because also they are asking in the examination. Okay, so I hope everything is clear for this question. Okay, you had a doubt that how we are going to understand that this is a one standard deviation. As I said dear, that first of all in your mind that you have to calculate, they had given us the value as 52 a kilogram is the mean value, and they had given, please listen carefully, they had given us a 52 kilogram of the mean weight of the woman, and they are saying the standard deviation is a 7.5 kilogram, and they are asking that what percent of the women will have the weight outside this range. So first we have to calculate in our mind that this weight range of 45.5 to 59.5 is in how much of the standard deviation. And we know that one standard deviation is 7.5. So we can say 52 minus 7.5 is your 44.5, and 52 plus 7.5 is your 59.5. So this is the range what they are giving us for one standard deviation. Clear? So by this we can calculate. So I hope it is clear to you now that how we are going to calculate the given value, it is in the one standard deviation or two standard deviation. Clear? Now going further, another question. A hypothetical study, a hypothetical study examining the association between the serum cholesterol, it is more than 280 milligram percent, and the cardiovascular disease demonstrates the relative risk of 3. Now here the one catchword is the relative risk. It means they are talking about which study. Now relative risk is calculated by which study? Please message me. I'll wait for your answer. The relative risk is 3, and relative risk is calculated by which study? Whether it's a cohort study, case control study, or cross-sectional study. Please message me that relative risk is calculated by which study? Excellent. So relative risk is calculated by the cohort study. Great. Very good. Very good. So they're talking about the cohort study. Now, what they are saying, when the data was matched, and we know that in the cohort study, we are doing the matching between the exposed and the non-exposed group. Now, dear, it is not a cross-sectional study, because in the cross-sectional study, we are not able to calculate the relative risk. So here quickly we'll revise that what are the parameters we are calculating by the various studies, because this is again a very important question. By the case control study, we are able to calculate the odds ratio. By the cohort study, we are able to calculate the relative risk, attributable risk, population attributable risk, and the incidence. And by the cross-sectional, we are able to calculate the prevalence of the study. Great. So here they are talking about the relative risk. It means they are talking about the cross-sectional study. And we know that in the cross-sectional study, we had a one group as an exposed group and another group as the non-exposed group. And we have to do the matching between these two groups. And matching is done to avoid the known confounders. We know this thing. So what they say that when the data was matched for the gender, means they had taken either the a male or the female, the relative risk for the man was 4 and the relative risk for the woman was of 1.5. Now earlier when they had not done the matching, the relative risk was the 3. But when they had done a matching for the gender, for the male it was the 4 and for the female it was a 1.5. So definitely here means the a gender or the sex of the individual in the study is affecting the study. So now they come to the point what they are asking, the most appropriate interpretation of the result is. So result is means we had seen when we had done a matching, then we are getting a different result. So it means it is a confounder and that is affecting the result. So here the gender is a confounder. Yes, this could be an answer. Gender is not a confounder, no, because it is affecting the outcome. So this is a confounder. Gender has no effect, no, because it is affecting, and gender is an accidental finding. It is not an accidental finding. So here the correct answer to this is that gender is a confounder. Now quickly we'll revise that what the confounder are, because again this is very commonly asked question. So confounders should fulfill the two qualities. The confounders are the factors which are number one, it is unequally distributed among the study and the control group or the exposed and the non-exposed group, and they had an independent effect on the outcome. So these are the two features of the confounders. That confounders are the factors which are unequally distributed and had an independent effect on outcome. And how we are correcting the confounding error, we know that we can do by the matching. Matching is correcting only the known confounders, and by the randomization we are correcting both known and unknown confounders. So this is a type of an error which we have to correct. So quickly we'll revise that what can be the different type of an errors we can come across in the epidemiological studies, because again the errors are very commonly asked in the examination. It can be the sample error while we are doing a study on the sample population, and we can simply reduce the sample error if we are increasing the sample size. Then it could be the systemic errors on the part of the individuals who are in the study. It can be the subjective errors or subjective bias. Recall bias, it is seen in case control study. Attention bias or the Hawthorne bias because of change in the behavior, it is in the cohort study. And the apprehension because of the anxiety, this is again in the cohort study. Or we can have the investigator error, it can be the selection error because of the error in the selection, and the interviewer error. And one more point, how we can remove the selection error, it is by randomization. And the third is the analytical error because of the error in the analysis. And how we can do the correction, again this is a very important portion commonly asked. And we can correct by the matching, which is correcting only the known confounding error, or we can have the randomization, which is correcting both known and unknown confounding error as well as the selection error. And the third is the method is the blinding. We can have the single blinding correcting the subjective error, double blinding correcting the subjective and the investigator error, and the triple blinding correcting the subjective, investigator and the analyzer errors. Now the point is that which is the best blinding? The best blinding is the triple blinding, but most commonly used blinding technique is the double blinding in our studies. So this is all about the various errors, confounders, and this question. Clear? So now I'll go further. Oh, such a long question. Now, as I said that if we are having a long question, then we have to read the last line and the options. So the last line is that the most appropriate test statistic to compare the result is the student pair t-test, unpaired t-test, chi-square test, and correlation analysis. So by reading this line and the options in 5 seconds, you can come to the point that they are talking about the various tests of the significance. And quickly the chart should flow in your brain that what was the chart, that which test we are using for the qualitative data and the quantitative data, and depending upon the number of the values. So I'll show you the chart and then I'll come to the question, because this is the way that how you have to approach. So this is your success mantra for the examination, to save the time and to come to the conclusion very easily. Because if we go with the question first, we don't know that what they are talking about, and then we, after reading the whole question, then we have to think, okay, they are talking about the test of the significance, and then to get a keywords again we have to read the question. So we are wasting the time by reading the question twice. So we know that they are talking about the test of significance and we know the flow charts. So our keywords what we have to identify is that they are talking about the qualitative data, or the qualitative test, or the quantitative value test. So this we'll try to find out. And the second point, we'll try to find out whether they are talking the how many groups are there, whether the two groups they are comparing, more than two groups they are comparing, and if they are comparing the two groups, it is the same group or the different group. Clear? So this is the three keywords what we have to find within this given question. So the flow chart should flash in your mind, and I'll first revise this flow chart before going to the question. That test of the significance, if it is the quantitative parameters are there, or qualitative parameters. Now question can come in your mind that how we are going to identify whether this is a quantitative parameter or the qualitative parameter. Now quantitative means if they are talking about the incidence rate, or if they are talking about the number which we can measure, it is the quantitative. But if they are talking about the percentage or the proportion, then it is your qualitative data. Clear? So if they're talking about the rate or the incidence, it is your quantitative. And if it is they're talking about the percentage or the proportion, they are talking about the qualitative. Now for the two groups in the quantitative, we are using the student t-test. If they are same groups before and after intervention, it is the paired. Two different groups, it is an unpaired. More than two groups, it is the ANOVA test. This what we know is the quantitative. And for the qualitative, we are using the two or the more unpaired, it is the chi-square test. And if they are comparing the two pair, then we are using the assigned test. So this is what is being quickly flashed in your mind. So now we have to identify that what type of the data, it is qualitative or quantitative, one thing, whether they are comparing the two groups or the more than two groups, or they are comparing the paired or unpaired, then we'll get an answer. So now coming back to the question, that a clinical training program wishes to evaluate the reliability of the self-assessment of the clinical skill as a tool of measuring improvement. After a teaching session, the students are asked to rank themselves on the scale of 0 to 1 on the 10 examination procedures. So they are not exactly measuring the value, they are not exactly measuring the rate or the incidence. They are simply saying the grade 1, 2, 3, 4, 5. It means they are talking about the qualitative data. So this point is clear that they are talking about the qualitative data. So now we have to focus on the qualitative data, are the chi-square test or the sign test. So for that we have to find out whether they are talking about the two same groups or the different groups. So first we had identified it, they're talking about the qualitative data. Now what they are saying, so on the scale of the 1 to 5 on the 10 examination procedures, the preceptor also ranked the students according to the same scale. So what they had done, the results of the two assessments are compared. So we had two groups, the two assessment groups. The one assessment is the students are ranking themselves. So this is the one group. And the second is the examiner or the preceptor is also ranking the students and they are comparing. So here it is the qualitative data, one thing. We had two groups, but these two groups are unpaired. Two different groups we are comparing. So qualitative data for the two unpaired groups, we are using the chi-square test. Clear? So this is the way that how we have to approach in the examination. So within a given time, we will be solving our question and getting the correct answer. Because if you're reading from the top, then we don't know that what they are asking about. But when we had gone from the below upwards, and then we know that they are talking about the test of the significance, and we have to identify these three keywords. Clear? So student paired t-test, no, because this is used for the quantitative paired data. Student unpaired t-test, no, because this is again used for the quantitative to unpaired data. And the correlation analysis is the ANOVA test we are using for more than two groups in quantitative data. Okay. So this is about your test of significance, very commonly asked in examination at your level also, in the PG level also, in the INICT level also. Okay. The next is that how many degree of the freedom should be used for the situation. Now, quickly by reading this, that we should be knowing that the degree of freedom is calculated by the chi-square test we know, and we should be recalling the formula that the degree of a freedom is equal to a column number of 1 into a row number of 1. Clear? So now we know that to solve this question, we should be knowing the number of the columns and the number of the rows. So what we have to do while reading the question, we have to find out that how many rows they are talking about and how many columns they are talking about. Then only I can calculate the degree of the freedom. So now see, consider the following study assessing the proportion of the patients presenting with the urethritis who were tested for the chlamydia trachomatis infection at the three different health centers. So this is a one point. They are talking about the three different health centers. So my three columns are there. Column number, this is the first health center, this is the second health center, and the third health center. Clear? So I got a one value, so three columns are there. And they are tested for the chlamydia trachomatis. And what could be the test result? That either the chlamydia trachomatis is present or absent. Clear? The data is analyzed using the chi-square distribution. They are already talking. They are using a chi-square distribution to determine if there is a significant difference in the proportion between the three health centers, how many degree of the freedom is there. So they are talking about the qualitative data. They are using the chi-square test. They are checking at the three different health centers. So we have the three different columns. And they are talking about the chlamydia trachomatis infection. And what can be the result that chlamydia trachomatis infection is present or absent. So we are having the two rows and the three columns. So we know now the answer to this is that we are having the three column and two rows. So my degree of freedom will be 2 into 1 as 2. So the degree of freedom for this is a 2. Clear? So by this question, simply I just want to convey the message that last line gives you the degree of freedom. So quickly you have to recall the formula for the degree of freedom and we have to identify how many rows and columns are there. Now you want to know in this, in the previous question, that how we are going to understand whether it's a qualitative data. Okay. Now here, because they say that students are asked to rank themselves on the scale. Suppose if they say that a test was taken and their absolute marks were calculated. Suppose they had given a test and the marks was compared. Then marks was the, we can measure. So that should be a quantitative data. But here what they are saying that measurement is done on the scale as a 0 to or the 1 to 5. So this is your qualitative data. Okay. So based on that, we can differentiate whether this is a qualitative data or the quantitative data. Clear? So now coming to the next question. In a survey, it was reported that 45% of the eligible couple are the target couple, and seeing the cost effectiveness of the procedure, which surgical method should be promoted. So before answering this question, we should be knowing that what is the eligible couple. We know that eligible couple are those couple who are eligible for the contraception. It means the age of the wife should be between 15 to 49 years, means the wife should be in the reproductive age. They are the eligible couple. Clear? And who is maintaining the eligible couple register? Who is maintaining the eligible couple register? Please message me. I'll wait for your answer. That who is maintaining the eligible couple register? Who is maintaining eligible couple register? Please message me. Excellent, excellent. Now, those who are answering the multi-purpose worker, it should be further specified that this is the multi-purpose worker female. So, multi-purpose worker female is maintaining the eligible couple register, and dear, it is not an Anganwadi workers, it is a multi-purpose worker female. And obviously, we know that multi-purpose workers are posted at the sub-center. So, eligible couple register is maintained by the multi-purpose worker female at a sub-center. Excellent, excellent. So, see how far you are able to remember. And you say that मैम हमने तो कुछ भी याद नहीं है, हमने क्या पढ़ा PSM सब भूल गए. No, no. If I am asking the question, you are very well answering the questions, and you are remembering. So this is the way that how we have to recall the past events. So coming to the point that eligible couple register is maintained by the multi-purpose worker, a female at a sub-center, where she is calculating, or she is recording that how many eligible couples are there, and the purpose is that we have to give them the contraceptive advice. Now, out of these eligible couple, the 45% are the target couple. So now, who are the target couples? We know that target couples are nothing but these are the type of the eligible couple, and those who are having the 2 or more live children. 2 or the more live children, it means they are at a main interest of using contraceptive, and preferably the permanent contraceptive, because they had completed their family size. Now the question is that we have to focus on the target couple, and target couple, they say that cost effectiveness of the procedure, which procedure should be performed or promoted. And we know that in permanent method of sterilization, we are having the 2 methods, either the tubectomy or the vasectomy. And we know that out of this, the vasectomy is more cost effective, because minimal instruments are required, the minimal surgery is there, the minimal stay is there. So we have to motivate for the vasectomy. So tubectomy, no, because it is not cost effective. Vasectomy, yes, it is cost effective, we have to motivate. Assure implant is again a type of a non-surgical tubectomy, and any of the above, no. So here the correct answer is the vasectomy. Excellent. So quickly we'll revise that what are the various permanent methods of sterilization. So this could be your image based questions also. This is the image of vasectomy, which is done in the male, more cost effective. This is the image of a tubectomy, but it is a mini laparotomy where we are ligating the tube with the modified Pomeroy's method. And this is your laparoscopic tubectomy, and we are using the Fallop rings most commonly in our national program, or we can have the Holka's clip also. And this is your non-surgical tubectomy, where we are using the Assure implant, and that is kept at the both cornal ends through the hysteroscopic insertion, and this is causing the inflammation, fibrosis, and the blockage of the tubes. So remember, one more point here is that is asked is that following the vasectomy and after the Assure implant, we have to advise the couple to use the additional barrier methods of contraception for 3 months, but that is not required for this mini laparotomy or the laparoscopic tubectomy. But it is advised following the vasectomy and the Assure implant, the 3 months of additional barrier contraceptive methods. Clear? Now, one more point they ask is that just after the delivery, we are using this method as mini laparotomy preferred, because we cannot use the laparoscopy just after the delivery, as well as in the patients who are having the cardiac or the respiratory diseases. Again, the mini laparotomy is preferred. Clear? So this is a one point. And another point is that we had already discussed that modified pomeroy's is in the mini laparotomy, and the Fallop rings is the most commonly used for in the laparoscopic tubal ligation. Clear? And the most common cause of failure, we know that is the wrong identification of the structure, and that's why we have to make a rule that after doing a tubectomy or the vasectomy surgery, whatever the piece of the tube is being removed should send for histopathological examination. So this is about your permanent methods of yes, a maximum success of tubal recanalization. It is not a maximum success of tubectomy with Hulka. Please correct this what you are understood, that if after the tubectomy surgery, suppose the children dies and the patient comes for the tubal recanalization, then we had a maximum success of tubal recanalization or tuboplasty if we had used the Hulka steel. It is not the maximum success of the operation. Clear? So please correct this point. Now the next question is, a 30-year-old lady reported in the emergency room with complaints of the severe abdominal pain. So one is the age is 30 years. She is complaining with the severe abdominal pain and the fever for the last 2 days. So these are the two chief complaints, the fever and the abdominal pain. On examination, the doctor noticed a purulent cervical discharge, tender uterus and the ethnic SAS. It means there is some infection because there is a purulent cervical discharge, the tender uterus and the ethnic SAS. PID picture is there. So there is a PID with the symptoms of the pain and the fever in a 30-year-old lady. When patient was examined, the visible IUCD thread was seen by the doctor. So now the picture is clear that IUCD is in place and the patient is having the pelvic inflammation presenting to you with the pain and fever. So what should be the action by the treating doctor? And we all know that if IUCD is there and the patient is having the infection, then we have to remove the IUCD and give the antibiotics. So reassurance, no. Reassurance can be given in the bleeding but not in the infection. Antibiotics, yes, we have to give the antibiotic. Now here again, now success mantra. Antibiotic is a yes answer to this question, but we are not going to stop. We may find some better answer. Removal of an IUCD, this is again a choice that we have to remove the IUCD because if it is an infection, and removal of an IUCD and give the antibiotic, this is the best answer. So please keep my words in your brain that if you are sure that your option number A or the B is the correct answer, still don't stop there. Just give a 5 seconds time to save a mark, and that is very very important in the end when we have to get a marks more than a 150 or 150 and above. Clear? So removal of an IUCD and the antibiotic is the best answer. Now quickly we'll see the commonly used IUCDs, because again these are the very important image based questions repeatedly asked in the examination, especially these two images. This is your copper T380. We are having the copper wire at the three places, as well as this Mirena. And Mirena, it is a T-like structure, but we are not having any copper. We are having this a capsule in the vertical arm which is having the hormone. So image number 1 is the Lippes, a loop. This is your Grafenberg ring. We had already discussed in our classes. And this is image number 3. It is your copper T380. This is in place, copper T80 with the thread hanging in the vagina, which is helping in the identification and the removal. And this is your image number 5. That is your Mirena. And this is image number 6. This is the multi-load. It is a C-shaped structure which is fitting in the uterine cavity, and any device which is having the thread, it is your IUCD, intrauterine contraceptive devices. And this is the same image number 6, image number 7, that is Mirana on one side and copper T380 on another side. And this is the image number 8. This is your FlexiGuard. It is a frameless copper wire which has been hooked in the uterine cavity to have this action. Clear? So these are the different type of an IUCDs. And the point what you have to remember, that the copper ICDs, their mechanism of action, they are preventing the fertilization. And the hormonal IUCDs, they are releasing the hormone, they are preventing the ovulation, they are making the cervical mucus thick and preventing the implantation in the endometrium. The next is that they are asking about the lifespan. The copper T 380 is having the maximum lifespan of the 10 years, and the Mirana, it is having the 7 to 10 years. The another question, the daily release by the hormone in the Mirana is the levonorgestrel, that is 20 microgram per day. Total is around 52 milligram. Now, another point is that what are the contraindications, very commonly asked as a clinical based suggestions also. The absolute contraindication is if there is a past history of an ectopic pregnancy, the presence of pelvic inflammatory disease like what we had in the management, the suspected pregnancy, or the history of the undiagnosed bleeding per vaginum. And other relative are the pelvic inflammatory disease, past history, nulli gravida, anemia, multiple partners, uterine perforation, and fibroids. So if these conditions are present, then we have to think twice before inserting the IUCD. And the complications, again commonly asked, the most common complication is the bleeding, and we are not going for immediate removal. We have to give the reassurance and iron folic acid tablet. But if the patient is presenting with the pain, then we have to do the immediate removal with antibiotics because there is an infection. Sometimes the patient can come with the pregnancy, and we have to remove this thread by the copper T by simply pulling the thread. Remember, in pregnancy we are not putting the hysteroscope. So these are the points what we have to remember about the copper T. Now, patient has came to hospital for medical termination of her 8 weeks pregnancy, and she requested the doctor that she wants an IUCD insertion as a contraceptive. When the doctor can put. Now, here remember the one point, although I think you might be discussing this in your obs-gynae classes also, that following the first trimester abortion, if you are doing a first trimester abortion, we can put a IUCD at the same time. But if you are doing a second trimester abortion, then we have to put an IUCD after a week. So if you are doing a first trimester abortion, IUCD at the same time, and the second trimester abortion, IUCD after the 1 week. And if you are having the delivery, again we can put the IUCD at the same time. Okay, so we can do an IUCD, put an IUCD after the delivery, whether this is a normal vaginal delivery or the cesarean delivery, and that what we say is a post placental insertion just after the removal of the placenta. Within the next 48 hours we can put the device, or after the abortion, we can just after doing an abortion we can put an IUCD if it is a first trimester, or if it is a second trimester, then after the 1 week we have to put the device. So the option is that immediately after the procedure, after 1 week, after 2 weeks, or after 4 weeks. So immediately after the procedure, we can put the device. Now, one more point we have to remember, that if a patient wants a family planning surgery or a tubectomy, then after the delivery, if it is a cesarean, then at the same time before closing the abdomen, we can do the tubectomy. And if it is the vaginal delivery, then just after the delivery, we have to settle, and after 24 hours we can do the mini laparotomy. सिजेरियन के साथ में तो उसी समय कर देते हैं बिकॉज एब्डोमेन खुला होता है, और अगर नॉर्मल डिलीवरी है तो आफ्टर 24 आवर्स till next 7 days we can do the mini laparotomy, but never the laparoscopy. Now, the Pearl index of a new contraceptive is higher than existing method. Now, we know that Pearl index is an index which is used for the efficacy of the contraception. And what is Pearl index is the number of the accidental pregnancies per 100 women year, or 1200 month of an exposure. And we know that more is the Pearl index, it means more is the accidental pregnancies or the less is the efficacy. So question is that Pearl index of a new contraceptive is higher. अगर उसका Pearl index ज़्यादा है, इसका मतलब failure rate ज़्यादा है, उसकी efficacy कम है. So more is the Pearl index, the higher is the failure rate, the lesser is the efficacy. So its efficacy in comparison with the previous one is low. Yes, because it is having the high Pearl index, so its efficacy is low. High, no. Same, no. No comment. So the correct answer is that its efficacy is low. We know that a contraceptive efficacy can be assessed by the two methods, the life table analysis. It is supposed to be the best because where we had a monthly analysis, but in the exam commonly we are asked with the Pearl index of the because of its special definition, and that is number of the accidental pregnancies per 100 woman years, or we have to remember as the 1200 month of an exposure. That is very very important because they can ask in the formula form also that it is multiplying factor is 1200, denominator is the total month of exposure. Okay, and we should be knowing the Pearl index of the few methods. The lowest is a Pearl index, the highest is the efficacy. So permanent methods, obviously the low 0.1 to 0.15. They had asked what I had marked. For the Mirena, it is 0.2. For the DMPA, it is 0.3. For the Chaya, it is 1.8 to 2.8. And for the diaphragm, it is 12. And we should remember the others also. Clear? Yes. This is again a very commonly asked question about the caloric intake. Mother and the Child Health Clinic. Obviously, in the MCH health clinics, the pregnant women or the lactating women are going. A nutritionist is advising a lady to take an extra 600 calories. And we know that extra 600 calories are given during the first 6 months of lactation. So what she is taking regularly, the most common possibilities means they had asked in a reverse manner that they had said that extra calories are recommended as 600. So what could be the situation? The situation is that she joined a new office for the work? No. She is pregnant by 6 months? No. Because in the pregnancy, the extra calories are 350. Okay. And if they're talking about the first trimester, in the first trimester, the extra calories are plus 150. But if they didn't mention and that it is the first, second, or the third trimester, then overall we say it's the 350 extra calories in the pregnancy. Lactating her 3-month-old baby, yes, because within the first 0 to 6 months, the extra calories are 600. And lactating her 10-month-old baby, no, because in the 10-month-old baby, the extra calories will be plus 520. So here the correct answer is that she is lactating her 3-month-old baby. Now, very commonly they are asking about the caloric requirement also, and although in the class also we have discussed the new guidelines, so here again we are discussing the new guidelines for the caloric requirement in the male and the female. So basic calories you can remember as in the female it is the 1700 kilocalories, and I had given you the formula that it is a plus a 4 means 400 is the 2100 in the moderate female, and plus 6 is 600, 2700 in the heavy worker female. And you can remember like this that moderate it is for sedentary male, and the heavy for the female it is for the sedentary for the moderate worker male. Or in another way we can remember like 2100 is the basic calories, the plus 6 for moderate worker male, and the plus 8 is the heavy worker male. So the calories for the female is 1700, 2100, 2700, and for the male is 21, 27, and 3500. And the extra calories we had already discussed that in pregnancy it is a plus 350, lactation for first 6 months it is plus 600, and after 6 months it is plus 520. So many times they ask a question like this also that 6-month pregnant woman, 6-month pregnant woman who is a moderate worker, 6-month pregnant woman who is moderate worker, calculate the caloric requirement. So please message me. I am waiting for your answer. My question is that calculate the caloric requirement of a 6-month pregnant woman who is moderate worker. 6 month pregnant a woman who is a moderate worker, what will be the caloric requirement? I'm getting a mixed answer. Uh, Now, please understand, because this is the point where we make the mistakes, and I think the many of you had made the mistake at this point. Now, here I am asking that 6 month pregnant who is moderate worker. So here we have to remember the 2 points. The one is that what is the caloric requirement of a moderate worker female. So some of you are answering the caloric requirement of a moderate worker female, that is 2100. You are right, but I am asking that a 6 month pregnant female, so you have to add the additional calories that is required in the 6 month of pregnancy to this basic, that is 350. So the correct answer should be a 2450 is the correct answer of the calories required by a 6 month female. Okay, so I hope those who had earlier made a mistake, they had understood. Now dear, I am asking, it is the 6 month pregnant. I am not asking she is 6 month lactating. So please read the words very carefully, because the examiner will give you all the choices. And that's why another success mantra is that on the day of examination you should be mentally and physically relaxed, and the day before the examination your sound sleep for 6 to 8 hours is very very important. And for having the sound sleep day before the examination, you have to change your sleep pattern minimum 15 days before the examination. Mind me these two words, okay? Because I know that currently you are reading till 2 o'clock, 3 o'clock in the night, and you are sleeping till 7, 8 o'clock in the morning. But in the examination, before the 15 days before the examination, you have to change your sleep pattern, and minimum 6 to 8 hours of the sound sleep is required. Because some are reading this question as lactation also, they are answering as plus 520 after the 6 months of the lactation. Some are reading only as a moderate worker, not adding extra calories in the pregnancy. Some are reading it as a heavy worker, telling me the 2700. So the mixed response I am getting. Clear? So that should be very very important success mantra for your excellent performance in the examination. Full concentration, proper reading and understanding the words, because whatever you are reading the brain should understand. If the brain is understanding it is as a lactating, it will answer like that. If the brain is understanding like a heavy worker, it will answer like that. So our eyes should read the things very clearly. So this is about the caloric requirement very commonly asked in the examination. Now the next question is, again, this appears to be a big question, but we will go in a pattern. That first we'll read the last line. Identify the type of the study. And they had given us a case control, retrospective, prospective cohort, and cross section. So, before reading the question, I'll first discuss that how we can identify the various type of the studies. They are giving us a various analytical studies. Clear? We had four types of analytical studies: the case control, a cohort study, cross-sectional, and ecological. So, how you are going to identify these three studies, that is case control, cross-sectional, and retrospective and prospective. I'll add a fourth one as the cross-sectional. Clear? Now here the direction. The direction in the case control, it is a backward. Because why I am saying that, because when you had read this question, immediately this table should flash in your mind, so that you have to identify what is the direction. And second point, what is the outcome at the beginning of the study? If you are able to identify these two keywords in the question, you will say that what type of study this is. So in the case control, the direction is backward, and in the prospective cohort, the direction is forward. While in the retrospective cohort, again the direction is forward, but from the point we have to go little bit back and then coming forward. Okay, so we have to go little bit back and then we are coming in a forward direction. So this is your prospective the retrospective cohort, and the cross sectional, it is at that particular point. So based on the direction we can identify. Now second is that what is an outcome of the study at the beginning of the study, outcome of the result. Now in the case control, the result is present. In the prospective cohort, the result is not with us because we have to wait for the results. And in the retrospective, yes, the results are with us, and the cross section also the results are with us. So if I say that results, if it is not present, then directly your prospective cohort, no confusion. And if the direction is backward, then obviously the study is the case control because no confusion. If it is at that particular point, that study is a cross sectional. But point is that how to differentiate between the prospective and the retrospective cohort, because in the both the direction is forward. So in that case, we have to look for the outcome. So if the direction is forward, it is a cohort study. Then to differentiate between the retrospective or the prospective cohort, we have to look for the outcome. If the outcome is present, it is your retrospective cohort. If the outcome it is not present, it is your prospective cohort study. So with these information, now we will be going for our question. Now the question is about the 1% of the boys are born with the undescended testis. This they are talking about the prevalence. To determine whether the prenatal exposure to the tobacco smoke is a cause of the undescended testis in the newborn. So they want to correlate the undescended testis with the risk factor as the tobacco smoke intake. The mothers of the 100 newborn with undescended testes and those of the 100 newborn whose testis has descended were a question. So they had two groups. The one are the 100 women who had already delivered because they had their newborn babies. So result are with us because of a newborn baby is there, we can assess whether the testis is descended or not. So outcome is already present with us, and these are the 100 female with the undescended testes are present, and 100 women where there is a descended testis is present. Okay, and what they are doing, they are questioning about the smoking habit during the pregnancy. Delivery has already been taken, and now they are going backward during their pregnancy duration and asking about the history of the smoking. So point is clear that outcome is with us, the direction is backward. So obviously what it is, and the study revealed the odd ratio of 2.6. This is again a very simple catch. Now, as I said that we should remember the uh, parameters calculated. Suppose if you are not able to identify with the given statement that what type of study is, and simply they say that a study is revealing the odds ratio. So this is a very important hint that odds ratio is calculated by which study? It is by a case control study. So here your correct answer is case control. So the hint for the case control, the one important is that an odds ratio is being calculated. The second is that the results are with us, the baby has been delivered, and they are asking the history of the smoking as the direction is backward. So all three are going in favor of case control study. I hope this is clear to you now that how we are going to identify the various type of studies. Okay. So dear, this is not a retrospective cohort because we are simply asking the history of the smoking in their pregnancy. Now Again, the same tests we had already discussed. It is done to compare the data. Why I had given another example? Because these are asked in the examination. So we'll say, because we know that for the qualitative and quantitative data, the different tests are used. So we have to first identify whether this is a qualitative data or the quantitative data, how many groups they are comparing. A study was done to assess the malnutrition in the young children, and 100 children were selected, each from the rural and the urban areas. So they are selecting the children from the rural and the urban areas. So two groups are there. The one is the rural area and another is the urban areas. And the 30 among the urban and 20 among the rural were found to be malnourished. So here they are simply saying that malnourishment present or absent, or they are giving us a prevalence of the malnourishment, that 30% are prevalent in the urban areas and 20 are in the rural area. So they are talking about the a qualitative data, because they are simply saying the malnutrition. Suppose if they say that the weight of the individuals was compared, so weight will be a quantitative data, but here they are simply saying the malnutrition was assessed, and we can say the malnutrition is present or absent. So this is your qualitative data. So the qualitative data is the two groups they are comparing, one in the rural area, another is in the urban area. So the test of significance will be your chi-square test. Clear? This is again we had already discussed another example, because again commonly asked. A study with a normal distribution has a median value of 150. So one catchword, the median. Now here again a point is that they had given us a median, but we know that they had mentioned a normal distribution pattern. So median will be equal to a mean value. So this is only a trick to confuse you, that you will be thinking that they have not given us a mean, but as the normal distribution, so median is same as the mean with a standard deviation of 10. So standard deviation is 10, and in a study of 68% of the population will fall between. So I hope you all can answer. So I'll wait for your answer. Please message me. So here they had given me the values, that a mean is a 150. I'm writing in a simple words. The standard deviation is a 10, and they are asking that how much will be the range of 68% population. And I'll give you the one hint, that 68% of the population is covering how much? Excellent, excellent. The all had answered very well. And we know that 68% is covering plus minus of the one standard deviation, and that is a 142, a 160. Excellent. So I'm very sure that you are not going to make a mistake for these type of the questions in the examination. One query is that you are able to differentiate, to identify that there's a qualitative data or the quantitative data. Now there, when you will be reading more and more questions, then you will be able to understand that what they are talking about and whether that can be measured or not measured. Based on that, we can say it is a qualitative or quantitative. Clear? Now, another is identify the type of study we had already discussed. A researcher wants to show the correlation between the COPD, chronic obstructive pulmonary disease, and the smoking, and he collected the patient records from government hospitals and the records of the cigarette sale from the government record. Identify the type of the study. Okay, now I'll explain the one point here is that how we can differentiate between the cross sectional and the ecological, because they are talking on that particular point. In the cross sectional and the ecological, both we are having the study on that particular point only, because they are showing that a correlation between the COPD and the smoking, and he collected the patient records from the government and the records of the cigarette sale. So they are not going in a forward or the backward direction, so it cannot be the case control, it cannot be the cohort. They're talking about at that particular point only, and that particular point, it can be the cross sectional or ecological. Now the basic difference is that in the cross sectional we have to examine the each and individual person, and we have to collect the information from the individual, that what we call as the primary data. And in the ecological, that we have to collect the information from the other source, and that is called as a secondary data. So here what they are doing, they are trying to correlate the COPD with the smoking. So if they have to collect the information from the individual, so they have to ask each and every person that how much cigarettes you are smoking per day, for how long you are smoking, but it is will be very difficult. So what they are doing, they are having the patients who are having the COPD from the government, and they are just getting the information from the shops, that how much cigarettes are being sold in the past few months. So it is the secondary data, they are not directly interacting with the patient, only they are analyzing the results. So here the correct answer is that it is your ecological study, because here they are collecting the information from the second source, sorry, secondary data they are collecting and they are compiling. Yeah. Now this is again a very common image, and in the 11th September NEET PG exam also this image was asked, and we know that this will discuss in we had already discussed in the nutrition with the vitamin deficiencies, and this will be also being discussed in your derma classes also, and it might be discussed in your biochemistry classes also. So here we know that his castle neck appearance is there, that pigmentation and the dermatitis in the sun exposed area, and this is none other than the condition related to the deficiency of the vitamin B3, that is niacin, and this disease is called as the pellagra. And we know the pellagra, we had a diarrhea, dementia, dermatitis, and the death. And which staple diet is prone for developing pellagra? Please answer me whether it's rice, wheat, pulses, or maize. So, which staple diet people are prone for developing a pellagra? Those who are eating rice, those who are eating wheat, those who are eating maize, or any of above. So this is seen with which staple diet eaters. Excellent. This is seen in the maize deficiency. Now, there who is answering me that this is a vitamin A deficiency. No, it is not a vitamin A deficiency, because in the vitamin A deficiency we are having the Bitot spots and the xerophthalmia. That is a condition. Okay, and this is a pellagra deficiency causing the castle neck appearance. Now, next question is, the 30-year-old person presents with the vomiting within the 2 hours of the food consumption at a party. So, a very short incubation period within the 2 hours of the food consumption in a party, the most likely organism responsible. We know that whenever we are eating a food, and if it is already having the preformed toxins, it is reaching to the stomach and will lead to the vomiting. And that is the mainly the staphylococcal group of the organism, where we had an incubation period of the 0 to 6 hours, and this is because of the preformed toxins what we are having in our food, and mainly presenting with the vomiting, upper respiratory, upper intestinal tract symptoms. Okay, and this is commonly seen if we are eating the milk products. If you are eating the milk products which has been prepared few hours before, not stored properly, getting contaminated with the staphylococcal. So staphylococcal food poisoning, it is commonly related with the milk products having the preformed toxins. Incubation period is 0 to 6 hours. Now Bacillus cereus, usually it is presenting with the vomiting and the diarrhea, both the types, and here the incubation period is commonly 6 to 24 hours, where it is presenting with the diarrhea, but it can be in the Some individuals incubation period of 0 to 6 hours when it is presenting with the vomiting symptoms, and it is commonly related with the fried rice. Okay, it is related with the fried rice. Now, Clostridium perfringens poisoning. Clostridium perfringens, it is related to the poultry products. It is related with the poultry products, and here the incubation period is around 6 to 24 hours. And the Clostridium botulism, it is related to the preserved food, and incubation period is again 6 to 24 hours, and this is presenting the neurological manifestation. Although this is a food poisoning, but it is not presenting with the vomiting or diarrhea, maybe sometimes constipation, but maybe the neurological manifestations are there. Okay, so these are the different types of food poisoning and their related manifestations. So here the correct answer to this question is staphylococcal, because it is related to the food, and within the 2 hours of the food consumption they are having the vomiting. Now the next is, yes, as I said, that the Bacillus cereus can also have the both the types of the poisoning, but most commonly what we say within a few hours is the staphylococcal, because already the toxins are formed. So, agar toxins are already formed and we are eating the food, then we can have the quick symptoms. But in the Bacillus cereus, the toxins are formed in our body once we eat the food, so it will take us some time. Clear? The next question is, 20-year-old boy reports to a clinic within 2 hours of acquiring a clean wound. So here the hint is that the boy reported to us within the 2 hours of the injury, and that the type of the wound is clean wound without the laceration. So clean wound without the laceration within the 2 hours he is reporting. And what is the next point is that he had received the TT vaccination last year only. So the immunization status is that within the last year he had received the TT vaccination. And we all know that active prophylaxis following the road traffic accident based on the two parameters. One is that what is the immunization status of that particular child when he had received the previous booster, and what is the type of the wound. So if you remember this flow chart which we had already discussed in our classes, that a type of the wound and the immunization status. So quickly after reading this question, this chart should flesh in your mind, and we have to identify that what is the type of the wound and what is the immunization status. And as all the parameters are going in the favor of the minor wound, because it is a clean wound, the child person is reporting within the 2 hours, so less than 6 hour duration. It is a non-penetrating wound, so obviously the minimal damage is there. So this is a minor wound. This is one point. Now second is, what is the immunization status? He had received the booster within last 1 year. Last 1 year उसने booster लिया था. So within a 5 year, so the answer is that no action will be required for this person, because minor wounds with booster last year. But suppose if it is the booster received the 7 years back or the 8 years back, then we'll give an TT injection in both the cases, if it is a major wound also. And if it is a booster more than 10 years back, then only the TT in the minor cases, but in the major type of the wound, we are giving the immunoglobulins also. So another point, that this is the condition where we are giving both active and passive immunization simultaneously. And what are the other diseases or other conditions where we can give active and passive simultaneously is in cases of diphtheria, in cases of hepatitis B, as well as in cases of rabies. So four conditions: diphtheria, hepatitis B, rabies, and the tetanus, where we can give the active plus passive immunization simultaneously, means vaccine and immunoglobulin are given simultaneously. So here the correct answer is that no vaccination is required because already had received the TT last year. Clear? Now the next is, now as I said that if an image is given, that we have to look the image, we have to read the last line, read the option. Most likely diagnosis. Some image, the tongue is widely coated. And what an option? The lichen planus, oral candidiasis, histoplasmosis, or oral hairy leukoplakia. Because in all the conditions we can have the white, either the patch, whether the lacy patches, ulcerations, or the white coating is there. So we have to read the option. HIV positive person. This is a very, very important clue that in the HIV positive person, it is not related to lichen planus. This is out. Because in the lichen planus, we'll study in your derma classes that we don't have this HIV positive. Separately with the lichen planus, we can have the oral ulcers. So this is out. And hairy leukoplakia, this is again out. Histoplasmosis, this is again a fungal infection. So first we'll see further. With a CD4 count of 300, this is again a very important clue because we know that based on the CD4 count, we had a various opportunistic infections. So again, this table is very, very important. We should immediately recall that what are the various opportunistic infections based on the CD4 count. If the CD4 count is more than 500, then no opportunistic infection is seen. Between the 500 to 200, the tuberculosis is most commonly seen in India and followed by the candidiasis, or we can have the Kaposi sarcoma. So here the in question, the CD4 count is given as 300. So this is going in this range, so more going in favor of candidiasis because HIV with the 300 of CD4 count. Now, if the count is between 200 to 100, then pneumocystis cerevisiae pneumonia, it is commonly seen in the world. Cryptococcus meningitis as well as the coccidioidomycosis. Coccidioidomycosis is the lung infection, fungal lung infection. Now, if it is between 100 to 50, it is toxoplasmosis, or we can have the cryptosporidiosis. It is a cryptosporiditis induced diarrhea we can have, or if it is less than 50, we can have the cytomegalovirus induced retinitis, or MAC is the Mycobacterium avium complex. Again, it's a lung infection. So here the keywords are that we are having the HIV positive person with a CD4 count of 300 and some white coated tongue. So the points in the favor of oral candidiasis. Clear? Then the next question is the drug of the choice for the treatment of this condition. Now this question I can say it is a integrated question between your pathology as well as the PSM. Now here they say the drug of the choice for the treatment of this condition. So if we enlarge this image and we say, although they had mentioned that this is the trophozoite form or this is the ring form, merozoite form, it means they are talking about the peripheral smear of the malaria infection. Now here the point is that we have to differentiate whether this is a Vivex infection or falciparum infection. So if you could see that the ring form, it is very small in comparison to the RBC size, one thing. Now we can have the some ring form, we can have the two chromatin bends are there. This is the second point. And the third, it is present at the periphery like a ring structure. So all these three features are seen in the Plasmodium falciparum infection. This is the peripheral smear of the Plasmodium falciparum. And further points in the favor is that we had a crescent shaped or the banana shaped gametocytes. And in the trophozoites, it is and schizons, it is nucleus is round. While in the vivax, if we see, so I can say show you, this is another picture where we are comparing the vivax to the falciparum. So in the vivax, if we say that this ring forms are bigger one in comparison to the falciparum. Now here the nucleus is round, where the nucleus is amoeboid, irregular is there, and the schizons, the RBCs are overall enlarged in the vivax, but it is of the same size, while the gametes are banana shaped or the crescent shaped in the falciparum, while it is in the round shape in the vivax. So overall, I can say that this is showing the picture of the Plasmodium falciparum, that is the peripheral smear. So here the two questions are there, because first you have to identify whether it's a falciparum or vivax. Because if you identify this as a vivax, you will say the drug of choice is a chloroquine. Okay, we'll read the question. A patient is presenting with a fever with the chills and rigors, and the peripheral smear report comes as shown. So simply they're talking about the malaria, and if you had identified this as a vivax, your answer will be chloroquine. They didn't mention about the patient pregnancy status, so the quinine is out because quinine is used in the pregnancy. Now, if you had identified this as a falciparum, your answer should be artemether and primaquine. Okay, and a chloroquine and primaquine with the vivax also. So here you have to go with one of these two, and you have to solve the two questions in one, because if you are thinking it is a vivax infection, you will go with the chloroquine with primaquine, but if you are thinking this is a falciparum, you will go with the artemether primaquine. As we know that this is your falciparum peripheral smear, so the correct answer for this question is that artemether and primaquine. Clear? Now quickly we'll summarize that what are the treatment protocol, because this is again a very important section. If I say from the community medicine in the National Vector-Borne Disease Control Program of the malaria treatment. Now the treatment in the vivax, the drug of choice is the chloroquine, to be given along with the primaquine, and we have to remember the dose of the primaquine, 0.25 milligram per kg per day. If it is a falciparum, then in the northeast states it's a artemether lumefantrine combination for 3 days. But if it is in other states, artesunate, sulfadoxine and pyrimethamine. Artesunate we are giving for the 3 days, and sulfadoxine and pyrimethamine single dose, and primaquine we are giving that 0.75 milligram per kg single dose is given. In vivax, we are giving for low dose for longer duration. In falciparum, higher dose for a shorter duration. Clear? But in the pregnancy with malaria, the drugs are different. In the vivax, it is only the chloroquine, no primaquine to be given. While in the falciparum, in the first trimester, the quinine is the drug of choice. You can remember the dose also, 10 milligram per kg, 3 times in a day for 7 days. And in the second and third trimester, northeast states is the artemether lumefantrine, other states artesunate, sulfadoxine, pyrimethamine, as well as primaquine is not given. So this is how we are managing a patient with a vivax or falciparum with or without the pregnancy status. Trophozoite is single large ring, then it is a vivax, and the falciparum it is multi-ring. Yes. So if it is a single, many times you can have a single also, but it is commonly the multiple, but they are the small. And you can remember like this, that in falciparum they are covering मतलब single अगर होगा, so they are covering the less than 1/3 of the cell size, RBC size. But if it is a vivax, then it is covering the more than half of the RBC size. So bigger one is a vivax, and smaller one is the falciparum, and commonly we can have the multiple rings also. Clear? Now coming to the next question. And please message me one more point, that which is the uh, best indicator, because indicators of the malaria program are very important. Which is the best indicator of malaria program? Which is the best indicator of the malaria program? Please message me. Best indicator of malaria program. I know you might be taking a few seconds to recall. Excellent, excellent. And I'm very happy that your preparations are going very good, very good, very good. It is an API, is annual parasite incidence. Excellent. Okay. And the indicator of the recent malaria transmission is the infant parasite rate. Okay. And the ARI, don't confuse, the ARI is an indicator of the tuberculosis, API is an indicator of the malaria, and it's an annual parasite incidence. Okay, API, ARI is annual rate of infection. It is for the tuberculosis, and the infant parasite rate is an indicator of the recent malaria transmission. Very good. Now coming to the next question. That again, this could be, I can see a integrated question of Dharma with micro or PSA. Clear? Now here you could see that they are having the rashes. The papular rashes are there on the hand, on the oral cavity, as well as on the fingers and the foot. So this is an image that is a hand, foot and mouth. The blisters, the small macule vesicles are there. So this is a hand, foot, mouth disease is there. So they are asking the causative agent. Now, if you are not able to guess that what this disease is, so we'll read. Otherwise, if you are clear that it is a hand, a foot, a mouth disease, and we know that a causative organism for hand, foot, mouth disease is none other than the Coxsackie A16 virus. Now, parvovirus, we all know that this is causing fifth disease or infectious a disease where we had slap cheek appearance, or fifth disease, what we say. Orthomyxovirus is having the causative agent for influenza, and the paramyxovirus, it is a causative agent for mumps infection. So, although that's why I said that it is more of your microbiology question. So the question is, a 3-year-old child is brought to a clinic. I think you are being studied in the pediatric classes also. A 3-year-old child is brought to the clinic by her mother, saying that a child is having the fever and the sore throat and the difficulty in the swallowing. On examination, we notice the blisters on the tongue, a lip, palm and the sole. So this is in the child with the blisters and the rashes on the tongue, lips, palm and the sole. So this is a hand, foot, mouth disease, and it is caused by Coxsackie A16 virus. Yeah. Now, true about the vertical transmission of HIV, the mother to child. Now we know that the mother to child transmission is about 30%, and we have to break this transmission or reduce the transmission rate as much as possible. So it depends upon, so they are asking about the true. So another success mantra, that we have to read the question very carefully, whether they are asking the false statement, they are asking the true statement, they are asking all are true except, all are false except. Clear? Because even a 1 mark is very important when we had a total calculation at the time of the result, And when in future you will be appearing in your PG entrance examination, now one correct answer can jump your rank up to 1000 or 2000, and one wrong answer can drop you by a rank of 1000 to 2000. So that is very, very important. Clear? So true about the vertical transmission, this depends upon the viral load. Yes, it depends upon the viral load. Transmission is more in the postnatal than intranatal. No, because the maximum transmission is in during the delivery, that is the intranatal period. LACS increases the risk of transmission. No, LACS reduces the risk of transmission by 50%, and mother to child transmission rate is 50%. No, this is 30%. So here the correct answer is that it depends upon the viral load. So how much is the possibility of the transmission from the one mother to the baby, and how we can reduce? So overall, if we see the route of transmission, that most common is the sexual route, and the risk is 1 is to 10,000. Then is the parenteral. The blood transmission risk is 95%. The needle prick is 1 is to 300. The needle sharing in the drug addicts is 1 is to 150. And the mother to child transmission is 30%. And the most important time is intrapartum or antenatal or the intranatal. And the breastfeeding is causing a transmission of to 12 to 16%. And we can reduce the transmission either by using the nevirapine to the baby, and from the existing 30% we can reduce by 50%, so the net result is 15%. And if we are using the ziravodine, and the transmission reduction is by 66%, so the net transmission rate will be 10%. And if you are using the cesarean section only, it is reducing the transmission by 50%, so the net transmission is 15%. But if you are using the cesarean with the nevirapine or azidovodine, then it is decreasing the transmission by 75%, and the net result is 7 to 10%. But remember one point, that this doesn't say that we have to use the cesarean section in each and every delivery of an HIV positive mother. Even the WHO says that in the developing country we are doing the cesarean only if it is on obstetric indication, because we had its own complication of the surgery. And if it is an obstetric indication, then only we have to do the cesarean section. Not only in the developing country, but even in the developed countries also, that cesarean section should be performed only if we had the obstetric indications. Okay, and if it is being used, then if we are giving the drugs, along with that we can reduce the possibility of transmission from the 30% to 7 to 10% only. So we'll discuss the last question before we can have a break. So the type of error they are asking. Okay, we know that in statistical analysis we are having the two type of an error. So before going to this, I'll quickly show you the table, because again this will be fleshing in your mind before answering if a question is asked about the errors. So we have to frame a null hypothesis. If null hypothesis is true in reality, if the null hypothesis is true and we are rejecting in our study, and we say that null hypothesis is not true, we are making a type 1 error. So you can remember like this, that your parents are giving an advice, you are rejecting, it is the type 1 error. Very simple way. So null hypothesis, in the reality it is true, but we are rejecting, and we say no, the difference is there, then it is a type 1 error. But if the null hypothesis is in reality it is a false, and we are accepting that okay, no difference is seen, then it is a type 2 error. So your friend is giving a wrong advice, you are accepting, it is a type 2 error, and the most dangerous is the type 1 error. So coming to the point, in an epidemiological study, the null hypothesis came out to be true. In a study, they say null hypothesis is true and accept. However, in the reality, the null hypothesis is false. So actually, the null hypothesis is false, and the false thing we are accepting as a true. So we are making a type 2 error. So null hypothesis, in reality it is false, but you are accepting because in the study you say it is a true thing, then we are making a mistake. So that is your type 2 error. So the type 2 error, the null hypothesis is false in reality, but we are accepting this. And if we say the null hypothesis is true in the reality, but we are rejecting, it is the type 1 error. The most dangerous is the type 1 error. So here we'll take a break of 20 minutes. So the time by my watch is 4:54. So we'll start our class at 5:40. Okay. And meanwhile, if you had any doubt, any queries, you can message. Hello, friends. Welcome back. I hope you all must have relaxed, must have taken a cup of tea or coffee, and back to discuss a few more clinical based situations. So, coming to the next question. Yes, it is again a very, very important point which is commonly asked in the examination about the rabies vaccination. Now, I try to put the important sections, otherwise, it is very difficult to compile all the things. So, we have to revise the important points, try to understand the concept, so we should be able to remember and solve the questions correctly. This should be our motto. Now, a veterinary doctor who treats the dogs should be protected against the rabies. Now, here they had not straightforward told us that whether they want to give the pre-exposure prophylaxis or the post-exposure, but we have to understand. Now, veterinary doctor, they are talking about a doctor who is treating the dogs should be protected. So, obviously, the doctor should be protected in advance. It means they are talking about the pre-exposure prophylaxis. That is very important to understand, because only then we can say that this is pre-exposure or the post-exposure. So they are talking about the pre-exposure prophylaxis of a veterinary doctor. Now, which schedule we follow? Now, we know that in the pre-exposure prophylaxis we follow a schedule, and that schedule is the 0, 7, 21 or 28. This is the schedule what we follow. So 3 dose schedule we are following. Now we'll see the options. The first 1 dose on the day 0, no. 1 dose schedule we don't follow anywhere. Then 2 doses on the day 0 and 3. Yes, we follow this schedule if it is a post exposure in already a vaccinated individuals. Then we follow the 2 dose and the day 0 and day 3. Now 3 doses on the day 0, 7 or 28, this is what we follow. And the 5 dose, this we follow as a post exposure in the non-vaccinated individuals. Clear? So here the correct answer is the 3 dose schedule, or 0, 7, 21 or 28. So quickly we'll see that what is the schedule in the rabies vaccination. Now pre-exposure is 0, 7, 21 or the 28 days, and we are giving the 3 doses, and the route is the intramuscular route we are giving, and our goal is to keep the antibody titer of more than zero point 0.5 international units per ml, and the booster is required every 2 years. Now, if it is a post-exposure prophylaxis in the non-vaccinated, we are giving the 3 regime. The ESN regime is most commonly used, that is a 0, 3, 7, 14, 28, or the Zagreb regime. This ESN regime is by intramuscular route. The Zagreb regime is again by the intramuscular route, but we are giving the 2 doses on the day 0 and day 7 and day 21. Some books they write the day 28 also, either the 21 or either the 21 or 28, but here the 2 doses on the day 0. Now the Thai Red Cross regime, it is the intradermal, that is the 22202, means the corresponding days are, that is a 0, 3, 7, 14 and 28. These are the corresponding days, and we are not giving any vaccine on the day 14, and the day 0, 3, 7 and 28 we are giving the 2 doses. Number 2 is there, the 2 doses, and we are giving on both deltoids. So this is by intradermal. Now one more question, if you have to remember that which schedule should be preferred, that best is the intradermal, because we are having the more antibody production and the lesser vaccine is required. But most commonly we are using the SM regime because of the technique of administration. Some of our staff is not very expert in giving the intradermal, so still we are using the intramuscular. Now in the vaccinated individuals, it is the 0-3 if we are giving the intramuscular schedule, or it is 4 site on the day 0 if we are having the intradermal. So this is the schedule. Now one more point we have to remember is the management. Now management depends upon the grade of the bite. If it is a grade 1 bite, that there is a lick on the intake membrane, then only the reassurance is enough. But if it is a grade 2 bite where there is a nibbling or the scratching without the blood, that's a grade 2, then we have to give the vaccine with the local cleaning. just do the local cleaning and the vaccine. And if it is a grade 3 bite where we had either the lick on the mucous membrane or the extensive bite with the blood, or we can have the multiple lacerated wounds, in that case we have to give the vaccine plus immunoglobulins plus a local care. Vaccine, immunoglobulin, and the local care. Okay, now immunoglobulin, one more point they ask is that how much should be the dose of the immunoglobulin. If we are using the human immunoglobulin, the dose is less, that is a 20 international units per kg the body weight. If we are using the animal immunoglobulin or the NT-sera, our dose is double, the 40 international units per kg the body weight. And the local care, the points what we have to remember, we have to do the thorough cleaning with the running water for a minimum of 15 minutes. No suture should be given for 24 to 48 hours, as well as we have to inject the local immunoglobulin. So we have to inject the local immunoglobulin, whatever the immunoglobulin we are calculating, we have to inject the totally in the local wound site. So this is about the local care. So this is all about the management of rabies, very commonly asked in the examination, the schedule and the management as per the grades. Now the next is the type of sampling. So here we have to simply recall that they are asking about the sampling methods, and we know that sampling can be the random sampling or a non-random sampling. So before going to this question, quickly recall that we can have the different type of the sampling techniques. If we go with the random sampling methods, now random sampling methods could be the simple random, that is like a lottery system that we have to randomly select, or it can have a systemic random that first from the given sample size we have to calculate the sample interval, that every n number we are going to calculate based on the sample interval, and this is a systematic random sampling. Or we can have the stratified random sampling, when we are having the four groups are there, and from each group we are having the random sampling. Or we can have the cluster random sampling. Now the cluster random sampling, the point to remember that this is used for immunization survey, and this is called as a 30 into 7 cluster, that we are having the 30 clusters and each cluster the 7 children are there. So total 210 children are studied. Clear? So this is about your random sampling, and the best is your stratified random sampling. Now what are the various non-random sampling methods? It can be the quota sampling, some group is selected, or it can be the convenience, whosoever is near we can select, or it can be the snowball sampling, whosoever is coming in contact we are going to select in further study, or it can be the volunteer sampling. So now coming back to the question, so we by reading the question, what is the type of sampling, quickly all these images or the method should flash in your mind. So what I mean to say, the success mantra is, while reading the question, within fraction of seconds everything should be playing in your brain like a video film, and this requires quite a bit of a revision, concentration, and the recalling power, because within a 1 minute what you have to do, you have to read, then you have to understand the question, the brain has to recall, remember, and then you have to answer and click on the computer screen. So these 4-5 activities we are supposed to do in less than 1 minute. So definitely we are doing more and more practice of these MCQs, what we are daily having on the Telegram group, we are having the weekly tests, we are having the discussions also. So this will train your brain that how to give the answer, or how to approach to a question within a least possible time. Clear? So now with the question, what we had understood, that they are talking about the type of sampling, and quickly the methods of the sampling should come in your mind. Now the question is, an investigator of a COVID surveillance team is collecting the blood sample from every fifth house. This is a very important clue, that every fifth house they are collecting the sample, means nth interval they are having. So in a systematic manner they are collecting the sample. So obviously this will be your systematic random sampling. Clear? This is not a simple random, this is not a stratified, because they are not making a groups, it is not a non-random. So this is your stratified random sampling. Now The question is, what is the sensitivity of the new test? So now quickly, you should be recalling the formula for a sensitivity. Now sensitivity, what we say is the true positivity. Now please message me that what is the uh, formula for your sensitivity. Please message me. What is the formula for sensitivity? I'm waiting. The formula for sensitivity. We know the sensitivity is true positivity, and if you can remember, I had given you the clue that for the sensitivity and the specificity, it is opposite. And for predictive value, it is the same. For the positive, it is all positive. For the negative, it is all a negative. Okay, if you're writing the true positive upon the total disease, then what is the total disease also? So that should also be very clear. So total disease, we say in the terms of what the total disease? Please clarify. Um, a true positive by true positive minus false negative. No, it is not a minus, it is plus, including the true positive plus false negative. You are coming to nearer to that point. Great. So this is your formula for sensitivity is a true positive by true positive plus false negative opposite. Clear? And what we can also write as A upon A plus C. Clear? So this is your formula for sensitivity. So now they are asking that what is the sensitivity of the test. So see that they are not telling us to have the calculation. So this is only a concept based, because in the exam we are not being given a rough page or the pen. So they don't expect us to do a major calculation. So they simply expect from us is the concept. So they are saying 80 by 1000, 80 by 100, 20 by 1000 or 20 by 100. So we have to find out what are the true positive cases and what are the false negative cases. That's all. In a population of the 5000. So population is hardly concerned, so we can forget this value. A new screening test is introduced which is able to detect the 80 positive cases. Okay, when the gold standard test was applied, the 100 cases turned out to be positive. So here the catch is that the gold standard test means it will be able to detect exactly the total number of the cases. So the total number of the cases of a disease in that area is 100. Means the sum of the true positive by false negative will be 100. Now out of these 100, actually how many are being detected as a positive by the new test is 80. So the true positive for this new test is 80. So 80 by 100 is my sensitivity. That's all. Okay, now if we say that I can write in a tabulated form also, for which what we had studied, that a total disease cases which has been detected by a gold standard test are 100, and out of these 100 the test positive for the new test is 80. So obviously the remaining 20 will be negative. So this is your A, this is your C. So the formula for the sensitivity is A upon A plus C. So that will be obviously the 80 upon 100. So they are not asking us to go to the further calculation. If we know the concepts, how to fill the values, and quickly we can come to the point. So here the correct answer is 80 by 100. Now see how beautifully the examiner has tried to trap you. Now they had mentioned 80 by 1000. Now, if you are not able to focus on the word, you think it is 80 and you had not seen the zero properly, that is the 1000, you may make a mistake. And mostly this type of the answer they keep on answer number 1 or the 2, and they hide the correct answers. So many of you can go with this, which is a correct answer, incorrect answer. So correct is 80 by 100. Clear? So this is how we have to calculate. Now quickly we'll revise that what are the formulas for the specificity. The specificity formula is, it is D upon a B plus a D, or we can say the true negative by false positive plus a true a negative opposite. What is the formula for positive predictive value, all positive, that is A upon A plus B, that is the true positive upon true positive plus false positive. And what is for the negative predictive value, all a negative, that is D upon a C plus a D, that is a true negative by a false negative plus a true negative. Clear? So this is what formulas we have to remember, and we should also remember that predictive value of a test depends upon the sensitivity, specificity, and the prevalence. And the sensitivity and specificity of a test is a fixed quality. It is not changing with the prevalence, but yes, if a prevalence is changed, then a predictive value can change. And another important point, that what is the relationship between the positive predictive value and the prevalence? It is the directly proportional. And what is the relationship of the negative predictive value to the prevalence? It is the inversely proportional. If a prevalence is increased, the negative predictive value will reduce and the positive predictive value will increase. Clear? And another point we should be knowing, that if we are having the high number of the false positive cases in a community, it can be either due to the low or disease prevalence, or it can be because of the high test sensitivity. So low disease prevalence and the high test sensitivity both can cause the more number of the false positive cases, but we had already discussed in detail that if the same test we are using, then the test sensitivity will remain the same, then the difference is only because of the disease prevalence. So these are the points what you have to remember in the calculation of sensitivity and specificity. Okay, now coming to the next question, the true statement is. So you have to read that what they are talking about. In the cancer treatment, the survival rate of the new modality of the chemotherapy is compared with the standard therapy, which shows the better results with a p-value of 0.03. Now the true statement is. So here they are saying that a new modality survival rate as compared with the standard. That a survival rate of a new modality, uh, just a minute. Sorry. So here they say that a new modality of the chemotherapy is showing the better results and the p-value is 0.03. So what is the true statement? Suppose if I say the p-value is a 0.3, then what it means? The p-value, if it is, because here the most important point is they are asking about the importance of the p-value. Now we know that p-value is nothing but it is the related to the errors, type 1, type 2 errors. So alpha is the maximum permissible type 1 error, the p-value is the type 1 error, how much we are making. So maximum permissible type 1 error. Okay, suppose we just revise with this chart, that we know that a p is the possibility of a type 1 error, the alpha is the maximum upper limit of the type 1 error, and we know that upper limit is 5%. So our error should be less than 5%, means our p-value should be less than 0.05 for the significant studies, and the beta is the probability of the type 2 error. So if our p-value is less than 0.05, means our error is less than 5%, we say our study is significant. And if our p-value is very low, our error is less than 1%, we say that our p-value is less than 0.01, it means our study is highly significant. So in this question what they are saying, that p-value is, if you go with the original question, that p-value is 0.03, it means our type 1 error is how much? It is the 3%. So it is acceptable type 1 error is there, and they are saying that a new modality is having a better results. So obviously this is a true statement that a new modality is better. So the true statement is the standard therapy is more effective, no, because they are saying that a new modality is showing the good results. The new drug is more effective. Yes, this is the true statement. Inadequate data, no, the data is adequate. No comment as of the high error. The error is low. Okay. Now, suppose if I twist this question and I say like this, that the survival rate of the new modality of the chemotherapy is compared with the standard therapy, and which shows the p-value of 0.3. And this means my the type 1 error is 30%. I'm making a too much of an error, so I cannot say that which modality will be better, because the new modality I'm saying better, but I'm making an error as the 30%. So in that case, my answer will be the no comment is possible, as the error is very high. So we cannot say that which modality is more effective, but here the error is quite low. It is within the range, and it is saying the new modality is better over the standard. So I'll go with the answer 3 in the original question. So I hope this is clear to you now. So this is what is the importance of the p-value, again very commonly asked in the examination. Now next is what is the level of prevention? Again, if a question is asked that what is the level of prevention, now quickly the table should flash in your mind that what are the different levels of prevention and how we are going to identify. So before going to the question, I'll summarize this table, that what we had already discussed in our classes in detail, that in primordial level prevention the risk factor is also absent, while in the primary, secondary and tertiary the risk factor is present. Means avoiding the risk factor is your primordial level prevention. But in the presence of the risk factor, if you are avoiding the disease is primary. So in the primary the disease is also absent, but in the secondary and tertiary the disease is present. And if you are early detecting a disease, means we are avoiding the complication. Now we can say one more point, that if you are doing a routine screening, sometimes the disease may be absent in the secondary also, because we are trying to early detect the disease. Now complications, we have to early detect a disease to avoid the complication is secondary. So complications are absent in the secondary, it is only present in the tertiary. And to avoid the disabilities is the tertiary level prevention. So disability may or may not be present in the tertiary level prevention. So this is how we are having the different levels of prevention. And we know that in the pre-pathogenic phase, we can have either the primordial plus primary level prevention, and in the pathogenic phase, the early it is the secondary level prevention, and the late it is the tertiary level prevention. And the primary level prevention can be of the, again the two types. It can be the specific, if for the individual person, and if it is for the whole community, it is the health promotion. So this is what are the different levels of prevention. So again, as I said, that when I read the question, that quickly all these things should flash in your mind. So a concept should be clear. Now we'll read the question. In last 24 hours, the 450 new cases of the corona disease reported from the Sadar Bazaar area of the Delhi. The next day, team from the health department visited that area and collected the nasopharyngeal swab of all the shopkeepers for the rapid antigen testing. So they are talking about that the cases were detected, high number of the cases were detected in that area. So what they are doing, they are trying to do a screening of all the shopkeepers to know that who are the carriers. So they are trying to do the screening, they are trying to early detect the further hidden cases. So obviously it's a screening, identification of the hidden cases. So this will be your secondary level of prevention. Clear? So no doubt should be there. Now, those who are answering it is primary, it is not primary, dear, because here we are trying to detect the infection in the other shopkeepers once we had come up with the 450 new cases. So it means the others should also be having the infection. They might be in the carrier phase. So we are trying to detect the hidden cases. So this is your secondary level prevention. Clear? Now coming to the next question, that again it is for the level of prevention we had already discussed. So I'll quickly read the question and you have to answer. A 65-year-old person with a known case of the diabetes and the hypertension brought to the medical emergency. So already a case of hypertension and the diabetes brought to the medical emergency with a history of the fever and breathlessness for the past 6 hours. Now SpO2 level was only 70%. X-ray chest was showing the right lung consolidation, rapid antigen test positive for the COVID. It means already a case of diabetes and hypertension brought in an advanced stage, because SpO2 level is 70% only, normally should be more than 95%, and the right lung is showing the consolidation on the chest X-ray, and the patient was immediately shifted to the ICU. In ICU, obviously, we are shifting the advanced stage of the patients, and oxygen therapy was given, and the donor for the plasma, means plasmapheresis was also being tried. So, obviously, what will be the level of prevention? Means it is a advanced stage of the disease, and we are trying to avoid the further complications and the mortality. So, answer is what level of prevention? Yes, everybody has answered the correct. It is your tertiary level prevention. Great. Now, what type of the study? Again, we had already discussed the different features to identify the study. I'll read the question, you have to answer. In a prospective study, prospective means a forward study, 1,000 patients of the diabetes were randomly selected to study the effect of a new drug. The drug will be given for 5 years, and its association with the retinal problems will be finding out. So we are giving a drug to the diabetic patients, and we are giving it for the next 5 years to find out the association with the retinal problems. So what can be this type of study? It is a case control study, it is a cohort study, cross-sectional, or RCT. What type of study this is? Okay, so this is the point where I was expecting some mistake from your side, and you had made the mistake, means I am able to trap you in a wrong direction. Now, as I said, it is a prospective study, forward study. So it cannot be the case control, and it cannot be the cross section. These two are out. Now we are left with the cohort study and the randomized control trial, or randomized clinical trial. Now the difference between, please listen carefully, the difference between the cohort and the RCT is, in the cohort study, we are starting a study on the healthy individuals, and we are exposing them to the risk factor and waiting for the disease to develop. This is what is the cohort study. But here the question says that they are starting a study on the disease individuals. So we are starting a study on the disease individuals who are having the diabetes mellitus. Clear? So in both the groups we had the diabetes mellitus cases, and what we are doing, we are checking for a new drug effect. So we are giving a new drug to the first group, that is an experimental group, and we are not giving a drug. Either we are giving a placebo, or we are giving the old drug. So here, if you can remember, we had discussed in the randomized clinical trial that it is done on the patients, and we have to check for the efficacy of the drug. And this we are checking them for the next 5 years for the development of the drug complication. So here, the correct answer is, it is your randomized clinical trial, not the cohort study. Clear? So remember the point that in the cohort we are starting a study with the healthy individuals, while in the RCT we are starting a study on the patients. Clear? And this is what is the diagrammatic representation of the RCT, that we are starting on the patients. We are dividing into the two groups. One is the treatment group, another is the control group. And if you can recall, we had discussed that the most important step by which we are dividing these patients is your randomization. And randomization is supposed to be the a most important step of an RCT, or the heart of the RCT, and this is avoiding your selection error and known and unknown confounding error. And we are giving them the drug for some time, and we are doing their follow. Okay, and this is what we had already discussed. If we are doing a study in the present direction, it could be your cross-sectional, or it could be your ecological study also. If you are going in a backward direction, this is your case control study. If you are going in a forward direction, it will be your prospective or retrospective. Prospective is directly forward, and if you are coming little bit back and then going forward, it will be your retrospective cohort study. Clear? So this is what this type of study is, RCT. Now, a 4-year-old child diagnosed as a case of diphtheria based on the history and the presence of the pseudomembrane. We know that in the diphtheria we use the pseudomembrane, and this was the one question asked in the June paper also, that they had given an image of a bull neck appearance, and they had asked us that what this is. That was a diphtheria bull neck appearance. And child has a 6-year-old sibling at the home who is fully immunized as per the schedule. What is the best measure to prevent this sibling? Because here they are asking that how we are going to deal with the close contacts in the family to prevent the transmission of the diphtheria, because we know this is a communicable disease transmitted through the respiratory tract, because a 4-year-old child has been infected. So the context management or the prevention what we can do, it may depend upon that what is the vaccination status of that person. Now if a contact children had received the primary or dose or the booster dose within the past 2 years, then no action is required. Clear? But if they had received the booster beyond 2 years, then we have to give the booster. So coming to this question, that they say that child elder brother, a 6-year-old, had received the immunization as per the schedule. Now you can ask, madam, that they had not mentioned whether the child had received the booster within past 2 years or more than 2 years back. So here actually the examiner has twisted the question, and they want to expect from you that you should know the normal vaccination schedule of the DPT also. So before going further, we should know the normal vaccination schedule of the DPT. Now we know that a DPT vaccine is started as 3 primary doses. First dose is given at 6 weeks, second primary dose at the 10 weeks, and the third primary dose at the 14 weeks. This is the primary dose. We are giving the first booster at 1.5 year of the age, and the second booster we are giving at 5 years. This is what the normal schedule. Now here the child is 6-year-old. This is the point. The child is a 6-year-old, and they say the child is having the full immunization as per the schedule. It means at the 5 year the child had received the booster. So definitely the booster has been given the 1 year before, and child is fully immunized. So within the 2 years means the 1 year before already the booster has been given. So coming in this range, so no action will be needed. Clear? So here it is little bit twisted question, but we have to understand and we have to answer. Or if a child was non-immunized at all, and in that case we have to give the antibiotic, penicillin or erythromycin to that child, as well as we have to give the antitoxin in the smaller doses, 1000 to 2000 units, and we have to give the vaccine if the this 6-year-old child was non-vaccinated. Clear? So here the correct answer is the booster dose of the DPT, no. Full course of the DPT, no. Already had received the full course. Erythromycin as chemoprophylaxis, no. And nothing is required. So this will be your correct answer. Now please listen carefully. Suppose in another exam, you are getting this question in a little bit twisted way. And what they say, that if they say that child had the 6-year-old a sibling in the family, and here who is not fully immunized, and if the question is that who had missed his second booster dose. If a question is given like this, the rest is same. Child has a 6-year-old sibling who had missed her or missed his second booster dose. In that case, what will be the answer to this question? Please message me. I hope you understood my question. I had twisted this question, that my question is that the same, the one child is having the diphtheria infection, and the sibling is not receiving the second booster dose. Then what will be the action? Okay, great, excellent. In that case, we will be requiring the a booster a dose of a DPT, because the second booster is not received. The first booster he had received at the age of 1.5 year. So the gap is now of 3.5, not 4.5 years. So in that case, the one booster will be required. Dear, we are not giving the chemoprophylaxis here, because already had received the three primary doses, the one booster. Chemoprophylaxis will be given if the child is absolutely non-vaccinated in that case, but already received the first booster, some immunity is there, we have to only the boost of the immunity. So here the answer is booster dose. Suppose if I say another twist this question like that, the child has a 6-year-old sibling who had not received any dose of the DPT. In that case, our answer will be that we are giving the erythromycin as a chemoprophylaxis, as well as the correct answer should be that we have to give the antitoxin also, and we have to give the full dose of a DPT vaccine. Clear? So, see, many times you may think that, okay, this question I had done in my test, or this question I had done in my telegram group, but examiner may twist a word. Even by twisting a one or the two words, your answer will change. So another success mantra is that never try to mug up the answers, because in the clinical situation, if they change the age, if they change the investigation, and if they change the any clinical symptom, your answer will be changed. So same clinical situation, the examiner can put in a different way. So try to understand each question has a different answer. So don't try to muck up the answers, and read the question carefully. Try to apply your concepts and then answer the question. Clear? So this is about your DPT exposure prophylaxis. Now, next question. Identify the type of the study. A study was planned to know the anemia status in the community. On coming Sunday, a camp is organized with a blood sample of the 1,000 individuals who are collected for hemoglobin estimation. Now, what is the type of study? Now, here we have to identify that what is the direction. Now, they say that we are collecting the blood, and simply by collecting the blood, they are checking for the hemoglobin. So, the direction of the study is at that particular point only. We are not going in a forward, not going in a backward. So, case control is out, cohort is out. Now we have to choose between the cross-sectional and ecological. I had already told you. Now if you are collecting the primary data directly, examining or intervening the patients, then it will be your cross-sectional. If you are collecting from the another source, it will be your ecological. So what will be the answer to this question? Yes, excellent. The answer is it is a cross-sectional study. Very good. Now another, you had a one query that if a child is a 25-year-old child fully immunized, then what will be the answer? Now 25-year-old fully immunized, because definitely we are having the last booster at 5 year. And one thing is that diphtheria is not very common in the adults, but still if we are exposed, then the answer should be the chemoprophylaxis. Clear? Yes, it is the cross-sectional study. Great. This is how we are having the cross-sectional study direction at particular point we are doing the study. Now the next is the correct answers are. So again, this is a multiple choices type question. A function of the health worker posted under the NRHM program. Now here they didn't mention as the worker, but they had mentioned that it is under the NRHM program, and we know that a NRHM program, the main worker is either the ASHA worker or the OSHA worker. Clear? And they had mentioned that it is covering the population of the 1,000, so definitely it is an ASHA worker, because the OSHA worker, the population coverage is, it is between the 1,000 to 2,500. We know this point. Now, what is the functions of this ASHA worker? Accompany the pregnant female to the hospital. Yes, because it is a part of the Janani Suraksha Yojana. They help in completion of the immunization as per the schedule. Now, please remember that they are not saying that they are giving the immunization. They are helping in the completion, means they are motivating them to go to the centers to get the vaccine. So yes, this is also a function of the ASHA worker. Now spread the awareness regarding the contraception again, because it is a part of the health education. And malaria slide preparation. So malaria slides are not being prepared by the ASHA worker, it is prepared by multi-purpose worker male. So this is not an correct answer. So correct answer is both A, B and C. Clear? So A and C, because if you think that they are giving the immunization, so you may mark as a answer B as wrong. But they are helping in completing, not they are giving the immunization. Clear? So here the correct answer is A, B and C are correct for this. Clear? And again, the health workers are very important. So these are the few images just to discuss. This is the image of the ASHA worker. And ASHA worker, in some states they are being given a pink dress, so they are also called as pink sari wali didi. And the most important is they are accompanying a pregnant woman to take to the hospital for promotion of the hospital deliveries. This is your Janani Suraksha Yojana, and in this activity they are being given some incentive to the ASHA workers as well as the patient. And it is different in the rural areas and the urban areas, in the high and the low performance states, which we had already discussed, you should be knowing. And she is also motivating the community to go for hospital deliveries, go for the antenatal checkup, go for the TT vaccination, and should be having the good nutrition vaccination of the children. So all these health educational activities are there. Now, can you identify the worker in this image? I'll give you the hint. This is the function what she is measuring the mid-arm circumference as a growth monitoring. This is what she is giving the education to the small children. She is vaccinating also, and she is also distributing the midday meal. So can you identify this worker who is forming all these four activities? Who is performing all these activities? Just a minute, you answer. So, yes, everybody has guessed the correct. Um, no, it is not an ASHA worker. Some had made a few mistakes that it is the Anganwadi worker. It is again not a multi-purpose worker, because the point in the femur of the Anganwadi worker is this point, growth monitoring. That is very important, because vaccination can be given by multi-purpose worker, but growth monitoring is not done by the multi-purpose worker. And midday meal also, it is not being distributed by the multi-purpose worker. And how the multi-purpose workers are functioning, I'll show you the images. This is what a multi-purpose worker female is working, that they are posted at the sub center, and at the sub center they are doing an antenatal checkup, they are doing the BP monitoring, examination of the pregnant mothers. After the delivery they are giving the postnatal visits, examining the mother, and they are also checking the blood pressure, giving the vaccination. So this is your multi-purpose worker female. And how this multi-purpose worker male looks like, the male is again sitting at the sub center and examining all the patients who are coming with the various symptoms and treating them. So this is the multi-purpose worker, a male. And this is what a multi-purpose worker female is, because lady is coming with a child for some problems. So this is how we have to identify these workers. Very, very important. We should be knowing the various functions of these workers. Now, Again, the test of significance, I had tried to put a 3-4 questions because you should be able to identify that which is the quantitative data or the qualitative data, two groups, more than two groups, like that. Now, most appropriate test of significance for this situation, a cardiologist want to study the effect of the new antihypertensive drug. Now, he recorded the initial blood pressure of the 50 patients and gave the new drug, and again recorded the blood pressure after the 10 days. The most appropriate test of a significance. So please message me. So first you have to see whether what type of the data this is. Now here they are measuring the, I'll give you the hint. Okay, first you answer, then I'll give you the hint if you're not able to answer me the correct answer. So what will be the test of significance in this? Excellent. So I think I am not supposed to explain because everybody is answering the correct. And here they are talking about the quantitative data, one thing. And they had two groups. One initially same group, they are giving the new drug, recording the blood pressure initially. Again, after the 10 days, they are recording the blood pressure of the same group. So two same groups before and after intervention. So definitely we are using the paired t-test. Excellent. So this type of the questions are very commonly asked at your level also, at the NEET PG level also. So the concept should be clear. Now the same again, a height of the two groups of 20 boys aged 10 years was 140 plus minus of the 15 centimeters, and the 20 girls aged 10 years was 135 plus minus of the 6 centimeters. The most appropriate test used to measure the significance of the difference in the height. Now again, answer for this question. Answer for this question. Okay. Now I think there is a little bit confusion between the paired or the unpaired. Now this is very clear that this is a quantitative data. They are measuring the height. So we are out with the chi-square test. Now they are measuring the two groups. One is for the boys, another is for the girls. So ANOVA test is also out. Now the difference is between whether it is a paired or unpaired. Now what they are doing, they are making a group A. This is for the boys, and where they are measuring the height, and the second group they are making of the girls, and again they are measuring the height. So they are comparing the two groups of the height, two other different groups. So we are having the unpaired t-test. Clear? Now the next is management include all except. If we cannot guess, then we have to read. A 27-year-old patient was diagnosed to have the lepromatous leprosy, okay, and started the multibacillary drug. Now we know that in the leprosy, the multibacillary drugs are given. Now 6 weeks later, he developed the pain in the nerves and the redness and swelling of the skin lesions. Now, this means that a person is having the lepra reaction. We had already discussed in our leprosy topic. You will be discussing further in your derma classes also. And here the patient is of a lepromatous leprosy, and we are giving the multibacillary drugs. And we know that what drugs we are giving. We are giving them the rifampicin, and rifampicin is given as 600 milligram oral supervised once a month. Then we are giving them the Depson. This is given as 100 milligram once a day. And we are giving the clofazimine. Initially, it is the 300 milligram oral supervised once a month. And then we are giving the smaller doses as 50 milligram a day. This is what is multi-drug therapy. And now the same treatment we are giving for POSI and multibacillary. Only the difference is that in the POSI-bacillary leprosy, we are giving for the 6 month, and the multibacillary leprosy we are giving for the 12 month. This is only the differences. Clear? And we know that two type of lepra reactions are there, the type 1 and type 2. If I show you the table, that this is what is the type 1 and type 2 lepra reactions, And type 1 is also called as a reversal, and this is because of the cell mediated immunity. You might be studying in your micro classes also that type 2 is a erythema nodosum leprosum, that is because of the humoral immunity. Now, a type 1 is commonly seen in both the types, the posse and the multibacillary, but type 2 is commonly seen in the multibacillary leprosy. And in the type 1, the main is that existing lesions become the red and the few new lesions appear. Means whatever the lesions are there, they become red and tender. But in the type 2, that is also called as erythema nodosum, means erythematous multiple nodules, new nodules, they appear. And the nerve lesions are more, or the whatever the nerves are there, they become more tender in the type 1, and the type 2 the nerves are less affected. And this type 1, another point is which is asked is, it is because of the type 4 hypersensitivity reaction, and the type 2 is because of the type 3 hypersensitivity reaction. Now we can remember the rule of 5, means total should be the 5, type 1 because of the type 4 hypersensitivity, and type 2 because of the type 3 hypersensitivity reaction. And the general symptoms are more severe in case of the type 2. When both the type, the point is that once a person is having the lepra reaction, we are not supposed to stop the anti-leprosy drug. That is very, very important. But in addition to that, we have to give some steroids or the depsone also. Some steroids are to be added to control the reaction. So this is what they are asking is that if the person is having the lepra reaction, the management includes all except. Stop the anti-leprosy? No. Never we have to stop the anti-leprosy. We have to continue. The systemic steroids are added. Yes, we are adding. The rest of the affected limb, yes, and we can add some analgesic. So all are true except is the stop the anti-leprosy drug. And this is the question what has been asked in the this NEET 2021 PG exam also, the same question. The person who's having a anti-leprosy treatment and has developed the painful nerves and the enlargement of the existing nodules, what to do. And the question was the same, that we have to stop the anti-leprosy and start the steroids only. We have to continue the leprosy treatment only, in the no extra drug is added, or we have to continue the anti-leprosy plus steroids to be added. So that was the correct answer for that. So very commonly asked a section in the leprosy. Now the next is, which of the following national program can help us? Now, we could not get any clue, so we will go with this. A recently delivered mother with a 15 days old baby is in need of the help as the baby is suffering. So, recently delivered mother with a 15 days old baby needs help as her baby is suffering with a fever, cough, and breathlessness. And she does not have the money to take the baby to the hospital. उसके पास पैसा नहीं है, वो hospital नहीं ले जा सकती. Then which of the national program will help? So basically here I want to ask from you that in which national program we are providing the free pick from the hospital, from the home, free stay in the hospital for the newborn babies, 15 days old baby, the free treatment and the free drop back. So please answer first, then I'll discuss this point. Okay, I'm having the mixed response. All the four options has been answered by you. Now, now we'll discuss one by one. Now, a facility-based IMNCI is the integrated management of the neonatal and the childhood illness. This is actually a component of the GSSY scheme. GSSK is the Janani Shishu Suraksha Karyakram. So the correct answer for this is it is a part of JSSK program. So what is the JSSK program is? It is a Janani Shishu Suraksha Karyakram where we had facilities for the both mother and the newborn baby. So maternal facilities are same as the Janani Suraksha Yojana, means a free pickup for the delivery, free stay, free delivery services, and medicines and some incentive and free drop back. But what is a baby components are? Now, initially when the program was started, we were giving the benefits to the children of neonates only up to the 28 days. But nowadays the facility has been extended till 1 year. Okay. Now, what the facility we are having? We are having the facility based newborn care, means we are hospitalizing the babies, and we had a newborn care corners, and each delivery point we had a newborn resuscitation table. Then we had a newborn sick units where we are or stabilizing units are there at the level of the CSCs, where we are having the 6 beds are there. The 4 beds are for the patients and the 2 beds are for the step down. Then we had the I think this is a component is missing here, and that should be the third is we had sick newborn care units, and these sick newborn care units are present from the district hospital onwards, where we are having the 16 beds are available, the 12 beds are for the patients and the 4 beds are for the step down. So this is a part of your facility based newborn care. We are having also the facilities of the nutritional rehabilitation centers, where we are hospitalizing the babies with a severe malnutrition and of the age group of less than 5 years. We had a integrated management of the newborn and neonatal and the childhood illness, and this is for the age group of the 0 to 5 years. And here we are having the management of the certain diseases like the diarrhea, ARI, malaria, measles, and malnutrition. And we should be knowing that we are classifying our babies into the 3 categories. And which health worker is doing this IMNC activity? It is the multi-purpose worker male. Sorry, it is the multi-purpose worker male, and we are classifying our babies into the 3 categories. The green means we have to give them the home-based treatment. The yellow means it is being given outpatient treatment, and we do the follow-up. If the patient is showing an improvement, we will continue the treatment. But if the no improvement is being shown, we are doing the referral of the baby. And in the pink category, we are giving the pre-referral treatment, and the urgent referral is there. And this is what is the IMNCI categories are. And so this is about your facility-based newborn care. And we are also having the home-based newborn care, and we know that home-based visits are being done by ASHA workers. We are having the 7, 6, and 5 visits. So here the question is that for the treatment of the baby who is 15 days old has to be admitted is a part of JSSK scheme. It is not only a IMNCI, because it's overall is a JSSK scheme. Now, what is a Navjat Shishu Suraksha Karyakram? Navjat Shishu means Navjat hota hai newborn baby. So this is actually a program where we are doing the training of the health workers, that how they are handling a newborn baby, doing their resuscitation to reduce the mortality. So this is a training program, and this is a 2 days duration training of the health workers, and our goal is to decrease the infant mortality rate. So this is not related to the treatment of the babies, it is the training of the health workers. And what is a Pradhan Mantri Matrutva Vandana Yojana? Now here, Matrutva Vandana Yojana, we are giving the incentive of the 5,000 rupees to a patient who is being delivered for the first time, and this we are giving in the 3 installment. The first 1,000 rupees we are giving after the completion of the first antenatal visit with the registration, and the second installment of the 2,000 rupees we are giving after the 6 month when she had already done one more antenatal visits, And the next, the last 2000 rupees we are giving 6 weeks after the delivery, provided the patient has been undergoing a hospital delivery and the baby had received the first dose of the vaccination of the 6 weeks and the mother is using any contraceptive after the delivery. So this is what is the Pradhan Mantri Matritva Vandana Yojana. Clear? This is what the logo is of the Pradhan Mantri Matritva Vandana Yojana. And another is the Pradhan Mantri Surakshit Matritva Abhiyan. This is also an important logo they can ask. And here the point is that we are giving the free antenatal care to all the women on the 9th of every month. And this is in the private sector, because in the government sector it is free, but in the private sector we are giving the free antenatal care to all the pregnant women on the 9th of every month. And we are putting the sticker on that, that if it is a green sticker, it means it's a low risk woman. If it is a red sticker, if it is a high risk woman. Blue sticker if it is having the blood pressure, B for blood pressure or the preeclampsia, or the yellow sticker if you're having the other associated medical problems. So these are the very important components of the RMNCH plus activity, and that is a part of National Health Mission. Okay. So there could be a logo based questions also. They can ask the direct questions also. Now the question is, we'll take the patient and go to the IMNCI centers. Now IMNCI activity may dear that it is the function of the multi-purpose worker. Now the patient will go to the multi-purpose workers nearest, and then multi-purpose worker will examine. And in that case, if he is thinking that this baby is sick, then the baby is being transferred to the higher centers. But here what they're saying that a baby is 15 days old baby and suffering with the fever, breathlessness. It means some severe form of the pneumonia is there. Then directly baby has to be transferred to the higher centers, and that case will be part of GSSK scheme, and IMNCI is a part of the GSSK scheme activity. Okay, so here the correct answer is the GSSK scheme. Okay, so IMNCI, it is not any center, it is the activity being done by the multi-purpose worker me. Okay, so I hope it is not a Navjat Shishu Suraksha Karyakram. Why? It should be clear. It is not a Matritva Vandana Yojana. It should also be clear. We had already discussed in a detail. Clear? Now coming to the next question. Now the next question is, a patient of the known case of the tuberculosis, that treated with the full course of 5 years back. Okay, had taken a treatment 5 years back and completely cured. Now he presents with the symptoms of the fever, cough and hemoptysis, and X-ray again shows the lung cavities. So again is having the chest infection of the tuberculosis. So he belongs to which category? So we should be knowing that what are the different categories. The category 1, these are the new cases of the tuberculosis, could be the pulmonary or the extra pulmonary tuberculosis. So this is the category 1. Now who are the category 2? The category 2 are either the relapse case, the failure case, or the defaulter case. So relapse is what? Is this case that already taken the treatment, cured, and again showing the symptoms. And what the failure means? The failure means on the treatment and not responding to the drugs. And defaulter means has taken a drug for few weeks, more than 4 weeks, but less than 8 weeks, and having a problem. So here this is the relapse case, and this is coming in the category 2. Now who are the category 4? Now category 3 had already been merged into the category 1. The category 3 or 4 are the MDR cases, that is the multi-drug resistant cases, means they are resistant to what drugs? They are resistant to the rifampicin and the INH. So this is the category 4. And who are the category 5? They are the XDR cases, and they are resistant to the rifampicin, INH, plus the drugs which we are using for the treatment of the MDR as the quinolones, and the a second line injectable. First line injectable we were using earlier was the streptomycin, and the second line injectable what we are using is the kanamycin or capreomycin. Kanamycin or capreomycin. So here the correct answer to this question is that it is for category 2. Okay. Now, although we had discussed the IMNCI activity, now classify as per the IMNCI guidelines the types of pneumonia. And before answering to this question, I'll quickly summarize that what can be the different categories of the pneumonia. And we all know that this category is based on the clinical features, because at the sub-center, we don't have any investigatory facilities are there. Now, classification of the pneumonia, we can have the no pneumonia, pneumonia severe or the very severe. And we should be knowing first the respiratory rate, the normal respiratory rate as per the age. Now, normal respiratory rate in the 0 to 2 month old baby, it is up to 60 beat per minute is considered as normal. In the 2 to 12 month baby, it is up to 50 beat per minute is considered as a normal. And if it is more than 12 month old baby, it is up to 40 beat per minute is considered as a normal. Now, if a respiratory rate is beyond this age, so that's why again I am saying that while reading the question, it is very, very important to know the age of the baby. Because if they say the 1 month old baby and the respiratory rate is 55, it is normal. But if it is a 10-month old baby, the respiratory rate of 55 may be abnormal. So we have to focus on the age. Clear? So quickly we'll see that what are the classifications of the pneumonia. The respiratory rate is normal in the no pneumonia, while it is increased in the other types of pneumonia. Upper respiratory tract symptoms are present in the no pneumonia as well as in the pneumonia, as well as the severe and the very severe. Everywhere the upper respiratory tract symptoms are there, but involvement of the accessory respiratory muscles, it is not present in the no pneumonia and the pneumonia, because in the severe pneumonia and very severe pneumonia, hypoxia is there. So there is an involvement of the accessory respiratory muscles, and leading to the indrawing of an intercostal spaces or flaring above the nostrils. Features of the shock is present only in the very severe type of pneumonia, and the pink categories are the severe and the very severe. The yellow is the pneumonia stage and the green is the no pneumonia stage, and we had already discussed their treatment, that a green is the ambulatory or the home based. Yellow we have to treat and do their follow up. Improvement continue, no improvement do the referral. And in the pink category, do you have to give the pre-referral treatment and urgent referral. Now coming to the question with this basic background. Now it is a 10-month-old child. So I say that age is very important. The age is 10-month-old baby. Is brought to the PSC with the complaints of the cough and cold. And on examination, the respiratory rate is 45 per minute. Now you have to correlate whether the 45 per minute for a 10-month-old baby is normal or abnormal. With there is no chest indrawing, no hypoxia, no involvement of the accessory muscles. So classify as per the IMNCI. I had given you the keywords: 10-month-old baby with a respiratory rate of 45, no chest indrawing. Then please answer me, what can be the condition? So dear, this is not a pneumonia case, because as I said that the age is important. Now till 50 per minute for a 10-month-old baby is respiratory rate normal, and this is a 45. So it's a normal respiratory rate. So I'll say that this is a This will be a no pneumonia stage. Clear? So this will be a correct answer. Just a minute. The question is that in the severe and the very severe, it is a pink or red. No, dear, now it is not a red. We say it is a pink category. So I hope this is clear because this type of questions are also very commonly asked in the examination. Now coming to the next question. A 20-year-old male is diagnosed as a case of dengue, a fever at the PSC. What are the suitable measures taken for prevention and the control? So they're asking both for the prevention and the control of the dengue in that area. So again, the dengue fever is very important. So before going for the options, we will discuss the few important points. Like dengue is caused by which mosquito? Please message me. The dengue is caused by which mosquito? Anopheles, Aedes, or Culex? Which mosquito is causing a dengue fever? Great. So it is caused by Aedes mosquito. And we know that what is the quality of the Aedes mosquito is that it is breeding in the artificial water collection. So this is a very important point we have to remember that Aedes are breeding in the artificial water collection. Why? Because in the prevention that we have to avoid this artificial water, either we don't allow the water to be there or we have to change the water every week because it is taking the 2 weeks time for the eggs to convert into the adult mosquito. So this is very important point for the prevention. We should know the breeding habits and how we identify the Aedes. Again, this could be a question that Aedes is having the tiger-like spots on the body and it is sitting parallel to the surface or sometimes it is having the hunchback appearance mainly in the culex, but it is also having in the Aedes and the lavas they are making an angle to the surface. So the most important is that either we will avoid this artificial water collection, that will be the primordial level prevention, and if you are not able to avoid the water, we have to put the chemical in the water, and this chemical has to be dissolved in water. So can you answer me that what chemical we are using? Can you answer me what chemicals we are using to kill these lavas? Sorry, dear. So the question is that which chemical we are using. It is abate or the temiphos. Yes, yes, yes. Those who are answering the sodium hypochlorite, dear, it is used for the disinfection. It is not for killing the larvas. And some had answered me the pyrethrum or the malathion. So pyrethrum, malathion, or the DDT, they are used to kill the adult mosquitoes as a space spray or the insecticidal spray. But I am asking that what chemical we are using to kill these larvas. So that's why I say the be very particular with the question. So in the larvas, yes, we are using the chemical as the abate or the temiphos, and yes, we can leave the larvicidal fishes also. And as but I am asking the chemical, and the opposite, the Paris green dust is used to kill the anopheles larva, which is the parallel to the surface. Clear? So this should be clear to you all. So now coming to the prevention of the dengue infection, what they are asking, that case management of the, because they are asking for the prevention and the control both. The case management of the dengue fever and the dengue hemorrhagic fever, yes, we have to do the case management. The case management of the dengue fever and the hemorrhagic fever, the mosquito protection, yes, we have to do the mosquito protection also. The vaccination, yes, we can give the vaccine, but it is not freely available. And the case management of the dengue fever, hemorrhagic fever, the mosquito bite protection by using the net, or the environmental measures for the control of the mosquito breeding site. So this is the best answer for prevention and the control of the dengue fever in that area. There, and we know that we are having the vaccine under the trial phase, that is the dengue vaccine, and this is a live attenuated vaccine, and we are having the normal saline as the diluent for this. And this is having the strain that was asked in a last year question, that is a CYD TDV. CYD TDV is the strain of this dengue vexia, which is the name given for the dengue fever vaccination. The 3 doses are being recommended, and this is a live attenuated vaccine to be dissolved in the normal saline. Now, can you answer me what are the other vaccines dissolved in a normal saline? So I'm asking, what are the vaccines dissolved in normal saline? Can you answer me? What are the vaccines we are dissolving in the normal saline? Vaccines dissolved in normal saline. I think if you're taking a long time, you might be turning your pages. That is not fair. Because the points which you answer immediately, it means you know. But if you are taking a long time, it means you are turning the pages. But at least I am happy with that, that you know where the answer is. Because many times the open book policy or open book exams are there, and where we, if we had not read that book, we don't know where the answer is. It means you are opening your notebooks and you are going to the right page. That's why you are taking the time. So the BCG is correct. OPV is dear, it is in the liquid form. And genuinely, you are accepting that you don't remember. I'm so cute of you, and I'm really impressed that at least you are accepting. No problem. But somebody had either remembered or writing it is yellow fever, Japanese encephalitis, BCG, and the hip. Yes, excellent. All four you had remembered. So if you are recalling, then 100% marks to you. But if you are doing a copy pasting, then it is not fair. So most commonly we are using the BCG and Japanese encephalitis. For yellow fever, we are again having a normal saline. The Japanese encephalitis, the phosphate saline buffer is there, and if it is not available, then we can use the normal saline. And Hib, it is again the normal saline. and the distilled water it is used for measles and MMR. So one more question was asked in the NEET PG that was about the Japanese encephalitis, and the question they had given like this, that there was an epidemic of an encephalitis seen in the Gorakhpur districts of Uttar Pradesh, and we had already discussed that the Japanese encephalitis is very common there. And the question was asked that which vaccine we will be using and what is the route of administration of the vaccine. So, type of the vaccine what we are using is the live vaccine, because we had both the type of the vaccines for Japanese encephalitis, but in our national program we are going with a live vaccine with a strain of assay 1414-2, and the route is subcutaneous. So, as I could gather the questions, around 23 to 25 questions were asked from the PSM section, and except one or two questions, I think all were at your level only, and if you had studied properly you could have answered those. So what I can say, that whatever you are studying for your FMG, don't consider that this is only for your FMG. You are preparing for your PG entrance also. So soon you will clear your FMG exam, then you will appear in your next PG entrance examination, and I am very sure that many of you who had already completed their internship, and if they pass this December exam, and I'm very sure that all of you will pass, then you will be eligible to appear in the next 2022 NEET PG examination, and many of you will crack that exam also, because whatever the questions we are discussing or the concept we are discussing here, the same concept you have to remember for your NEET PG exam also. So this is what is about this question. Now coming to the next question, uh, camp was organized to know the obesity status of the woman and where the waist hip ratio was being calculated. So they are asking about the waist hip ratio and what should be the cutoff level of the waist hip ratio in the woman to label them as obese. So we all know that waist hip ratio is an indicator of the obesity, and in the male the cutoff will be a 1, and in the female should be more than 0.85. So they are asking for the female. So the cutoff for the waist hip ratio in the female is 0.85. Now another parameter where we are not considering the height or the weight is the mid-arm circumference, and we know that mid-arm circumference can be, or the skin fold thickness rather I can say, it is by the Herpenden skin caliper, and the most important site is the mid-arm, this mid triceps, where we are measuring the skin fold thickness, and the cutoff for the male is around 18 millimeter and the female is 32 millimeters. Now other sites for calculating this skin fold thickness could be the mid biceps, or could be the anterior abdominal wall, or the scapular areas. And other very important indicator is the Quotient index on the BMI index. So BMI is very very important, and questions has been asked from the BMI index, and it is the most important WHO obesity index. The formula we have to remember that it is weight in kilograms by height in meters square, and the cutoff for the obesity in general, if they don't mention the Asian or the world, as per the WHO guideline, it is 30 or more is the cutoff for obesity, and the morbid obesity is if it is equal or more than a 40, and the BMI less than 18.5 is considered as the undernourishment, and BMI cutoff for Asian countries like India, it is 25. So if a BMI is 25 or more in India, it is considered as the obese, or the WHO guideline it is 30 or above. The other parameters for calculating the obesity is the Pontral index. This is usually used for measuring the obesity in the children, and the formula is the height in centimeter by weight in cube in kilograms. Now Broca's index is height in centimeters minus 100 is your actual weight, And if the weight is more than that, it means you are having the obesity. So your actual weight should be that height in centimeters minus 100. Now, Copley's index is the actual weight by the desired weight, and if this ratio is more than 1.2, it is your obesity. So we have to remember the Quetelet index in the detail, and the name of the other indexes only the Bondral, Broca's, and the Copley's, because sometimes they ask that all the indexes are related to obesity except like a Chandler index, the Pearl index, because we know that Chandler index is related to hookworm, and Copley's this Pearl index is related to contraceptive efficacy. So this is about your obesity indexes. Now, one more question I'll ask, because I had mentioned the Chandler index. So you have to message me that what is the cutoff level for the Chandler index. When we can say it's a major public health problem, when the Chandler index value is between 150 to 200, or 200 to 250, or 250 to 300, or it is more than 300. When we can say that it is a major public health problem, when the Chandler index value is, what should be your answer? When we can say it's a major public health problem, when the Chandler index is of which you can write as a B, C, D, whatever you want. Great. So if the Chandler index is more than a 300, yes, excellent, excellent. Everybody is writing a correct answer. We say it is a major public health problem when the Chandler index is more than 300. And what the Chandler index is, we all know that it is the a number of the hookworm eggs per gram of the stool is your Chandler index. Clear, excellent. And this is related to your hookworm. So these are the a few questions which I had tried to summarize. Now, one more question I just want to ask about the hookworm, because this is again a very commonly asked section. That what is the drug of choice for the hookworm management? What is the drug of choice for the hookworm management? So please message me. What is the drug of choice for hookworm management? It is mebendazole, metronidazole, or albendazole. Mebendazole, metronidazole, or albendazole. Which is the drug of choice? No, dear. A fluconazole is not there. Fluconazole is antifungal. Fluconazole is antifungal. Yes, it is the albendazole. Not a metronidazole also. The albendazole is the drug of choice for hookworm management, and that's why, if you can recall, we are having the biannual deworming. We are giving, means every 6 months we are giving the albendazole tablet of a 400 milligram toward school children in the age group of 2 to 19 years. So every 6 months we are giving them the tablet albendazole as a deworming under the school health. Now, next question is, every 6 months what other things we are giving them? Now, every 6 months, we are giving them the vitamin A supplementation. Every 6 months, we are doing their eye checkup. Every 6 months, we are doing their health checkup. So, every 6 months, we are giving them the albendazole tablets, giving them vitamin A supplementation, doing their eye checkup and the health checkup. Now, every week, what we are giving them? Every week, we are giving them the prophylactic iron folic acid tablet, and daily, we are giving them the midday meal. So remember, because frequency is very important and commonly asked in the examination. Clear? Now, one more point is that what should be the cutoff level of the referral, because if you're doing an eye checkup in the school, so the eye checkup is mainly done by the school teacher, and the teacher is responsible for the 150 students to check for the vision, and the vision, if it is less than 6 by 9, that the child is being referred to the primary vision center for further correction of the refractory errors by the paramedical ophthalmic assistant. Now, suppose if a school teacher is not given in your option, then who is doing an eye checkup in the school, we can go with the primary vision center or the paramedical ophthalmic assistant. And so answer me another question, that how much is the population coverage by the paramedical ophthalmic assistant? How much is the population coverage of the uh, primary vision center, or we can say the paramedical ophthalmic assistant? How much is the population coverage? How much is the population coverage? Because these are the points under the program of blindness. So how much is the population coverage of excellent, excellent. So the population coverage of primary vision center or the paramedical ophthalmic assistant is 50,000. Now, if you can remember, we had discussed a chart that we are having the primary vision center. It is covering the 50,000 population. Then we are having the service center or the secondary vision center, which is covering the 5 lakh population. Then we are having the tertiary vision center, which is covering the 50 lakh population. Then we are having the center of excellence, which is covering the 5 crore population. And then finally we are having the apex center, and that apex is covering the whole country. Clear? And another point is that we are having the ophthalmologist from the secondary vision center onwards. Now, ophthalmologists are not present at the primary vision center. We are having only the paramedical ophthalmic assistant. So, ophthalmologist, the minimum population coverage is 5 lakh. We are having the minimum population coverage of the specialists, which are posted at the community health center, is 1 lakh, except the ophthalmologist, which is 5 lakh, because they are being posted as per this program. And the cutoff level of the blindness is if a vision is less than 3 by 60 in the better eye with best possible correction. So the vision is less than 3 by 60 in the better eye with the best possible correction, we only say that the person is blind. Okay, so these are the important points what I had tried to discuss. So before winding this session, if you had any doubt, any query about any portion which you want me to repeat, you can message me, so I'll repeat that section again. Any doubt in any query regarding any question or any portion of the community medicine which you want that it should be discussed again, I'll be discussing. Please message me. Okay, you want the categories of the blindness. Okay, so categories of the blindness, if we say, we had a vision as per the new classification and as per the old classification. Okay? If our vision is between 6 by 6 to 6 by 80, If we had a vision between 6 by 6 to 6 by 18, we say it is a normal vision, or as per the new classification, it is the grade 0, and as per the old classification, it is a new normal vision. Now, the grade 1 of blindness, if the vision is between 6 by 18 to 6 by 60. Now, grade 1 in the new classification, it is called as the mild visual impairment. Mild visual impairment. And old classification, we can say it is the low vision. Clear? Now, if the vision is between 6 by 60, less than 6 by 60 to 3 by 60, if the vision is between less than 6 by 60 to 3 by 60, as per the new classification, that is the category 2, we say it is a severe visual impairment, and the new classification. As the old classification, it is showing as the economic blindness. Economic blindness. Now, if the vision is less than 3 by 60 to 1 by 60, as per the new classification, it is the category 3, we call as the blindness. Now, in the category, as per the old classification, we call it as a social blindness. Okay. Then, if a vision is less than 1 by 62, perception of the light present, in the new, we say it is a blindness category 4, but in the old classification, we say, so economic blindness, social blindness, then it is a manifest blindness. And if the vision is less than perception of the light to the perception of the light absent, in the old classification, we say it is the absolute blindness, while the new classification, it is again the category 5 blindness. Okay, while the category 9 blindness, it is in only the new, and where we can say it is unspecified, where we cannot specify it in any of the category, that is the category 9 blindness. So this is what sometimes a question is asked, that the vision in the right eye is this, the vision in the left eye is this. So we have to go with the best vision in the one eye, and with the best possible correction, and we have to see that what they are talking about is they are talking about the old classification or a new classification. Okay, so this is what is the various categories of blindness. Now another is now way of the preparation for the exam in the terms of the PSM, as we had a few days left. Now, dear, I think you had attended the classes very sincerely, and you had read the content once also, and you had underlined. So you know the concept. Now, only then thing is that you have to read quickly the underlined points. Means you are not going to read each and every point. Then you also already know the concept, and you have to quickly revise. Like if you are reading a topic of screening, so we have to simply say this is a secondary level prevention. The types of the screening are prescriptive and prospective, the mass or the mass screening or the high risk screening. Then you have to remember the formulas. Then on what it is, sensitivity is affected by, specificity affected by, prevalence is affected by, positive predictive values affected by, and what are the various screening tests, like that. So within a 10-15 minutes time, you can revise that section. So you're not going to read again in the thoroughly, because already you had studied. So you have to quickly revise the highlighted points. Now another is a rotavirus vaccine is a powdered vaccine. Now rotavirus vaccine, dear, it is available in a liquid form, but we are giving it with a buffer saline. So we are not having any diluent for the rotavirus. We are mixing with the buffer saline, and this is being given. Okay, so no diluent is required for the rotavirus vaccine. Now you want to know the identification of the studies again and the sensitivity and specificity. Now identification of the study, if I go to the question, what we had already discussed here about the identification of the various studies, this was the point. That identification is based on that we have to identify what is the direction of the study and how is the outcome. Now, if you are able to identify the direction, if it is the backward and the results are present, then it is your case control study. If you are able to say that it is the direction is forward, and if the result are present, then it will be a retrospective. If the forward result is not present, then it is your cohort study, prospective cohort study. Or if it is the forward and we are studying on the patients and studying the effect of any drug, it will be your RCT study. And if it is being done on the same point and collecting the information from the patient, that is a case control cross-sectional study. And if you're doing on that particular point and collecting the information from the secondary sources, it is your ecological study. So this is how we are going to identify the various studies. Now the next is the sensitivity and specificity. Now sensitivity is the true positivity, means whatever the actual disease cases are there, and out of those disease cases how many cases are being detected by this test, it is the sensitivity. And how many are the total healthy cases and how many are being excluded by this test, that is the specificity. So specificity is the true negative by true negative plus false positive, and the sensitivity is the true positive by true positive plus opposite, that is false negative. Clear? Now the protocol of the tuberculosis and the treatment. Now protocol may nowadays you have to remember this point as because we had studied that chart, and if I don't want to confuse you, you can remember like this, that nowadays we are doing the X-ray chest and the sputum examination both in the first sitting in adults, if you talk about the adults. And out of these two tests, the sputum is still considered to be as the best test. Now if a sputum is positive for the AFB and even the X-ray test is negative, still we will label them as a tuberculosis confirmed case microbiologically. And what we do, because on the same sitting we have to look for the sensitivity of the test, because even a first case is being detected new case, we can think that this could be a resistant case. So even if it is a sputum is being positive for the AFB bacilli, we go for the CBNAT test. That's why we say the most important test now is the CBNAT. But although we don't apply in the first test, but first we do the sputum smear. If it is positive, we go with the CBNAT. And if the CBNAT is showing the sensitivity or resistance to the rifampicin. If it is sensitive, then we'll go with the same as a category 1 treatment for the 6 months. The 4 drugs, HRJD for the for 2 months, and then HRE for 4 months. The total is the 6 months. But if the rifampicin resistant, then we'll deal with as a MDR or the XDR cases based on what drugs they are sensitive. Clear? But if the sputum it is negative or the X-ray it is non-suspicious, still a person is having the clinical features, then we can go with the CBNAT. So ultimately CBNAT तो आपको करना ही है, चाहे आप डायरेक्ट कंफर्म केसेस में करो या नॉन कंफर्म्ड है तब करो. So if we are doing a CBNAT and we are detecting the CBNAT is detecting the this tubercle bacilli, we go with the sensitivity, and this is the what the protocol is. But in the children, the protocol is a little bit difficult because we are not having the sputum properly available. So we'll do an X-ray test, or we are doing an Montauk's test, or we are doing a test for latent tuberculosis. And if we had a doubt that X-ray is suspicious, and then we'll try to demonstrate the bacilli. So if we can take a sputum, it's fine. Otherwise, mostly what happens, the child swallow the sputum. So we'll just put a lavage tube in the stomach, and we take a gastric lavage, and on that we'll directly apply the CBNAT. And if the CBNAT we are able to detect the bacilli, and then we'll go with the sensitivity. That is what we are doing in the pediatric tuberculosis. Okay. So either we are taking the induced sputum or we had a gastric lavage. So this is how we are detecting. The treatment, you have to remember, only for the first category, for the 2 months and the 4 months, 4 drugs and the 2 drugs. And in the MDR and XDR, I don't think they ask the exact drugs. You can just remember the duration of the therapy. Okay, and remember the new drugs what we are using is the delaminid and bedaquiline for the treatment of MDR and XDR cases. And the drugs in detail you will be discussing in your pharma classes, where you can remember that uh, so in MDR and XDR cases, you can simply remember the duration. Not the drugs exact treatment is not asked, but you can remember their mechanism of action, what you will be discussing in detail in your pharma classes. Now, important logos for the exam. The important logos are there, the logos of all the national programs, what we are discussing time to time, and the important logos for, or the important images of the various routes of administration, or various screening tests like a wire test or the Willy test, the various levels of the prevention. And I think all these images are available in your app study material also. So important that you have to study the logos of the national program. Then you have to study the routes of administration of the vaccines that are also asked, the storage of the vaccines that are also asked as a image. Then VVM is also very commonly asked, the vaccine vial monitor. Then if you see in case of the insecticidal sprays, they can have the various levels of prevention, and the images in the disease cycle. They are having the images of the various disease cycle like a Japanese encephalitis, the Nipah virus, and in the nutrition, you should be knowing the growth chart images, and the logos of the Anemia Mukta Bharat, the midday meal program. Environment mein you should be knowing the images of the various insects also. So and the various instruments like Kata thermometer this year was asked in a NEET PG, the logo of the Kata image of a Kata thermometer. So like that, these are the few important images what you have to remember. Now, PSM images PDF, I think it is already there in your study material in the MIST mobile application. So you can go there. All the images are there. Clear? So there the images are, the chapter wise images are there. So if you read a particular chapter, you can go with the images of that particular chapter. So I think most of the queries are done. So can we close the session here if you don't have any further query? So with these words, I'm closing a session here. Once again, wishing you all the very best and good luck. And in the last, I can say that you have to believe in yourself, believe in God, that definitely the tomorrow is going to be better than today. Now, you might be feeling low today, but don't worry. You just go on doing your hard work. कर्मा करते जाओ, रिजल्ट की चिंता नहीं करना है. You have to do your own karmas, you do your work with full dedication, with the 100% or even more than your 100%, and leave everything on the God. Everything will be fine. And I always say that to open a locker, we are having the two keys. The one key is your key of hard work, and the second key is your key of luck. Now, the hard work you have to put, and if you are constantly going to put a one key in the locker, Now the bank official is going to put in another key and going to open the locker, and that bank official is nothing, is the god, none other than the god, and who is having your second key of the luck. If you are constantly putting your hard work key, then definitely the god is supposed to put a key of your luck and going to open the locker, and where already your certificate of MCI passing certificate is lying, and you all are going to have your passing certificate. So with these words, wishing you all the very best for your 100% success in the examination, not only in the examination, in the future life also. And we are always with you. Whenever you had any problem, you are most welcome to ask your queries at any time. Okay, so bye bye, take care, all the best.